and Gynecology Society and ISOPAB Bhopal chapter. And today's topic is Twice the Trouble Managing Complexities of Multiple Gestation. Let's start with a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
And at the start, I would like to welcome Dr. Monica Singh, who is the convener of this webinar series. She is the President-elect Bhopal Obstetrics and Gynecological Society, Founder President ISOPAB Chapter of Bhopal, National Executive Member of ESAR, Joint Secretary cum Joint Treasurer MPIAGE, and Coordinator for FOXY Infertility Committee. Welcome, ma'am, and over to you.
Thank you very much, Dr. Vivek Sharma from Team Intas for giving us this academic platform to collaborate today in the Synergy Club with the Jabalpur OBGYN Society and ISOPA Bhopal chapter. Today on the 19th day of June, Thursday, we have gathered here to discuss whether multiple gestation is twice the trouble or are we just making a big issue out of it. But all said and done, the complexities of multiple gestation can perplex and trouble any obstetrician, and it is very much imperative that every obstetrician is updated in her skills and in her knowledge in order to take the help of fetal medicine specialists right from the start of determining the multiple gestation to determining the amnionicity to correctly and timely diagnose the complications, deal with them as and when they arrive, and of course, try to reduce the number of multiple gestations, which are still counted as success in ART pregnancies, but they are actually not. So today, I'm very happy to get together and present to you this beautiful webinar, which has been granted for ICOG points. And for the points, we are very thankful to Jabalpur OBGY Society, President Dr. Rakhi Bajpai Madam, and Secretary Dr. Komal Jain. Today there are stars in the sky and there are stars on earth. So we have a brilliant star amongst us to bless us as chief guest, and that is Dr. Mandakini Megh Madam. Madam is past chairperson ICOG, and I would like to welcome her. Can we have a CV, please? I'm very honored to welcome Dr. Mandakini Megh ma'am amongst us. And last Thursday, when the webinar was due, it was a very unfortunate day for the whole world, especially India. And imagine this crash took place in Ahmedabad, and Ahmedabad is the heart of our studio where we start this program. So the first person I called at 2 p.m. or 2:30 p.m. was Mandakini ma'am. Madam was so busy that day. She was attending multiple meetings all over Mumbai. And the first thing she told me, Monica, mat karo. Don't do. And my heart was also saying no. I know Jyoti would have said no. Everyone would have said no. So we postponed it. And imagine again, it's a Thursday. 7 days have passed after the disaster. And 7 days have given us lot of food for thought that live for the present, enjoy the present moment, live for your loved ones, express your love for your loved ones, do what makes you feel happy. Whether it is Foxy, whether it is work, whether it is family, whether it is cooking, swimming, traveling, but do it safely. And Madam, I'm so honored to have you amongst us. Speaking about Madam is like lighting a candle in front of the sun, but still I would like to warmly welcome Madam as the Chairperson ICOG Foxy 2021 and President of Association of Medical Women in India's Central Council and first time elected International Vice President of MWIA Central Asia. This is big feather in the cap for our country, And this,
May I correct you? That is a previous one, but recently I have become the world president of this organization, Medical Women International.
yes, sorry, madam, sorry, ma'am. Yesterday,
Oh,
yesterday we were discussing this, but madam, I'm so sorry.
No,
And
because
madam is
everybody should know. Everybody should know
now.
that women power.
Yes.
India has brought so much laurels to the women power, and I think I'm backed by all you people, Indians, and this honor is for everybody. And everybody is congratulating me because there were many from the Europe, and Germany contestant, but everybody withdrew for me, and I became the unanimous world president of the Medical Women International.
Good evening, madam. Congratulations,
Thank
madam.
you. And then my installation will be in the Cairo, and next month I started my innings chief guest in the China Medical Women Association. So I'm so sorry, sorry, Monica, but you just continue for 1 minute and then it's okay.
No, ma'am, it's my mistake that I could not do the designation properly. But ma'am, you have taken over as president on an international forum, and it is such a proud moment for all of us. And it has given us a vision of what guidance you are going to give to hundreds and thousands of Foxians who will follow your path.
Correct. Thank you.
Madam has also held very important posts in Foxy. She has been a torchbearer in Foxy, vice president, various committees of FIGO Committee on Infections During Pregnancy, a very proud resident of MP, our own state of Madhya Pradesh, city of the holy city of Mahakal, Ujjain, where she has, spent her childhood, and she speaks fondly about all MP, her memories. She's also been the member of AOFOG Reproductive and Sexual Health Committee.
I think
Past
Monica
president of
yeah.
Yes, ma'am. Ma'am,
Yes,
I
go
just wanted to mention how much active you are in the government of, though you belong to MP, you are ours, but you have given your entire power and your wisdom and your acumen to the government of Maharashtra. You have worked with the Family Welfare Department, Health Department of Mantralaya in Mumbai. You have been the Deputy Director of Health Services, Government of Maharashtra. You have been in charge of family welfare, RCH, PCPNDT, MTP, and other committees, and also maternal health consultant for the UNICEF portion of Government of Maharashtra. Written so many books. Always have a good word for everyone. Always take out time to talk to whoever knows you and whoever approaches you. And very down to earth, madam. Very simple at heart. And ma'am, we are so lucky that we could get your time.
Thank
Ma'am,
you. Thank you, Monica.
and we would like to have
Can you stop sharing for a minute here?
Please stop sharing, Vivek.
So I think thank you very much, Monica. It's a pleasure and I was excited. So I was before time. जब भी MP की बात निकलती है तो खुशबू कुछ अलग आने लगती है. Whether it is webinar, whether it is something distance, पर खुशबू तो आ रही है. So I'm, दिल से खुश होती हूँ. तो बहुत अच्छा लगता है. And I think जो सबने कहा, Sita will agree because she is a member of our West Bengal branch. She knows how much it takes to just being the national president, which I am now at the present, and among so many foreign dignitaries who were aspiring to become the world president, I think, Sita.
Absolutely, madam. It's a great honor. Congratulations.
And everybody congratulating me that 117 years of jinx I have broken, and the India was given this very coveted position. Even the Leslie Regan madam was in the fray, and they say, Mandakini, oh, very nice. So what I'm trying to convey to all my juniors who are here, and I have my guests like Jyoti Banglowala, Yadav, Sumitra, all my very favorite people here. And जबलपुर तो बहुत ज्यादा फेवरेट है ज्योति. मेरे आप लोगों से कहना क्या है कि those who are very sincere and their genuine approach, they will never ever fail in the life. That my success in the international level has taught me that मुझे कभी कभी लगता था कि अरे ठीक है, ओके, दैट दिस लेवल नाउ इट्स ओके, नाउ लेट अस relax and enjoy life. But suddenly this came into way, and this is the life what Monica was trying to tell us in a very philosophical way कि पिछले थर्सडे को we lost so many and we are all reading, I don't want to repeat it, but the जीवन कितना क्षणभंगुर है और जीवन के लिए कितना मतलब we have to value each and every moment. We should be so human that I think the human touch itself is a very rare. हम लोग तो भी इंडिया में इतने सब हैं. I get so many my foreign friends coming from say USA, सबके आते होंगे, but मेरे तो बहुत पुराने हो, 40 साल पहले चले गए. Whenever they came, I keep a very nice, dinner, lunch, get together, and they value those golden moments so much. Similarly, on this webinar, हमें पहले लगता था ठीक है यार ये तो रूटीन है. No, no, no. मैं पहले आ गई थी because I think we are gaining energy from each other. Huh? And this is not theoretical. Sita, it is not theoretical. I'm just trying to convey. It's real. And I think मैं थोड़ा जरा philosophical हो गई हूँ, but then I think I am extremely happy. We draw energy, and I am going to guide each and every one of you, including become the member of World, apart from Foxy, of course. But I also want to tell each and everyone that the first president of Foxy, Dada Bhai, Dodi Bhai, Dada Bhai, she was the MWA president first. And because Foxy was new, ours is 117 year, Foxy is 75 years. So they say because you have, experience of AMWA running national, you should be guiding the Foxy to become the national. So that was the reverse. It was not like that. So I think we draw a lot of history, women power. And now I want to come to the subject that complexity. Today's is a very interesting topic. And complexities of your multiple gestation, we have hundreds of cases I can narrate here, especially after coming head in the second twin was a great dilemma. And in those days, Sita and Monica and even Jyoti will not believe, I don't know, हम लोगों को जस्ट पेशेंट ऊपर चढ़ा, ऐसा देखा, थोड़ा पीटर को तो लगाया, चले गए. तो once when I delivered, I was so tired after 6-7 seizure in the night. I went home and my sister says, "Madam, दूसरा बेबी निकला अभी." Then I did not know this is a twins also. That was actually happened. Madam, दूसरा बेबी भी निकल रहा है. Oh, I said, then see what happens is there's no diagnosis, no ultrasound. You can imagine. And how many cases you examine? 400 cases of ANC. So what, you people are extremely lucky that you got fetal medicine specialist, you got all the specialists here. And I think as Monica has correctly mentioned, that because of the infertility treatment, because of the ART treatments, we are getting more and more twins. And generally in the earlier, I am not very expert in the infertility, but earlier they were saying, okay, theek hai, do hai to. There was no fetal reduction or, things like that. Even at one time when I was in charge for the MTP also, even they were questioned how you can, reduce the second baby, which may come into the purview of the MTP also. Sometimes we have faced those earlier days. But I think with the advent of people like Sita, Chinmay, and all the ones, I mean, the things are wonderful. And I'm extremely happy that हम लोग ने दो बैंड के रेडियो से शुरू किया, तो नाउ वी आर एट द आर्टिफिशियल इंटेलिजेंस. हम लोग वो पीढ़ी है जो हमने सब कुछ देखा है. सो विद दिस आई थिंक आई एम एक्सट्रीमली हैप्पी. थैंक यू वेरी मच. आई एम ऑनर्ड, मोनिका, सीता, ज्योति यादव, एंड ऑल द इवन रणवीर.
यस मैम, नमस्कार मैम.
तुम्हारा फोटो मैं हमेशा सबको दिखाती हूँ. मोनिका, भोपाल टेस्ट ट्यूब सेंटर एंड वन ऑफ द बेस्ट सेंटर्स. तो आई एम योर स्पोक्समैन एंड आई थिंक थैंक यू वेरी मच फॉर ऑनरिंग मी एंड कम फॉर माय कायरो इंस्टॉलेशन. फिर आप लोग फॉक्सी सब भूल जाओगे, सब आ जाओगे।
नहीं मैम, मैडम आपका मार्गदर्शन मैडम, आई रिमेम्बर स्टिल 10 years back when you visited my center as a national inspection in charge of the PCPNDT, and it was like कि CBI के 10 लोग आ रहे हैं, and I particularly, so madam you have guided everybody, I think in PCPNDT medico legal guidance to you as a Foxy member, helping each and every member, and we are very thankful to, and we are proud that you belong to our state from Ujjain. Thank you ma'am.
And the last thing which I want to say, please help each and every person. Please
Yeah.
help, without keeping anything in mind.
Yes
Because
ma'am.
मैंने आपके यहाँ से हम लोग जब डॉक्टर विराज के यहाँ गए, वो बोलते नहीं हम तो सील कर देंगे। अच्छा, अरे 150 पेशेंट बैठे हैं। एंड आई फॉट फॉर हर, शी वाज नॉट नोइंग आल्सो। मैं झगड़ा किया, आई सेड नो। एंड देन धार में जाने के बाद दुबई के लिए कलेक्टर को डांटा। व्हाट आई एम ट्राइंग टू से, आई एम नथिंग दैट, but you should have that kind of thing, then only you can really gather. And that is the quality of a leader. You know, they don't keep anything mind, and they are so inclusive. And I think, thank you very much. I'm becoming a little emotional
Right.
with the
And madam, you are no ma'am, you are on the top of the Foxy member, madam, out of 45,000 who helps each and every, and she feels the proud on helping.
Thank you.
हमेशा माँ बाप ही बच्चों को मैडम हेल्प करते हैं, लेकिन आपने पूरे फॉक्सियन को अपना बच्चा या जूनियर या यंगर ब्रदर सिस्टर ही माना मैम.
I'm
Thank
born
you.
for that, born for that.
Yeah,
So,
yeah, ma'am. Thank you.
thank you everyone, and I'll take your leave because I got another
Yeah.
meeting.
Thank you.
Thank you. Thank you.
much.
Thank you.
Thank you so much, Mandakini ma'am. Thank you, ma'am. Moving on, after the emotional dialogue with our chief guest, we come to our guests of honor. And we have our guests of honor today, none other than our very, very beautiful colleagues from Indore, Dr. Sumitra Yadav, madam, and Dr. Jyoti Banglowala. Madam has joined. Sumitra madam has joined. Purva? Purva?
Hello, hello, ma'am, am I audible?
Yes, Sumitra madam has joined. Purva, can you call her,
No,
please?
yes,
So
ma'am, I'm calling.
I will first introduce Jyoti.
Jyoti, ma'am,
Yeah.
Jyoti, ma'am.
Can I have Dr. Jyoti Banglowala? We have among us.
Monica, don't please give an
No,
introduction.
no, no. I will give your introduction in my way. I never read the CV. So I speak from my heart. And God has been kind to give me some, some eloquence in that way that I can speak about my friends and people who are very close to my heart. So Jyoti Banglowala from Indore. I did not even know FOGSI of Foxy 3 years, 4 years back. I was total ART person, all Isarian. Everything was Isar IFS. So जब पहले कदम फॉक्सी में रखे, कुछ समझ में नहीं आया, बस एक ही को फोन किया, डॉक्टर ज्योति बंगलोवाला. So that is why we are on first name terms, though she is senior to me, with due respect, but I call her Jyoti. And she never objects, and she responds very sweetly. So she is my mentor in Foxy. My baby steps in Foxy were because of her. We can see her illustrious, she has worked hard. So I can say when Dr. Sunita Tandalwadkar is working hard from Pune as the epicenter, I think she has got multiple fulcrums all over the country. One fulcrum in MP and northern and central India is being held by Jyoti. So Dr. Jyoti Banglowala, it will not be Atishokti to say that you are holding one very key worker position in Madam's army, and that army is dedicated towards bringing about change. Foxy needs change, and the change is perceptible throughout the country. Dynamic programs, outspoken candidates, very different way of looking at things, podcast, launches, one-to-one dialogue with everyone. Chairpersons are so approachable. Programs are so meaningful. Even people like me are being given an opportunity to speak. So this is just because of you are holding 30 key committees, and we are proud of you in MP. So Jyoti, some words from you, please.
Yeah, Dr. Monica, one few seconds from me. Dr. Jyoti, she is very dedicated to medical legal, and she has been attached with me in 15 years when we SAR founded, and all in medical legal problems she used to discuss with us. Though I was not knowing that her passion will be medical legal, but she loved the medical legal part. So now, Dr. Jyoti, the platform is for you. Thank you.
Thank you, Monica, and thank you, Randir, for the words you are actually saying. It is not actually 10% true. having all our colleagues. and all
100% true.
See,
Thank you,
we are endorsed by Sita ma'am.
Yes.
Absolutely.
So actually, first of all, I just want to extend congratulations to Monica and Randir because you are now the stalwart in conducting webinars. That the way you are conducting webinar, the topics you are taking, and the actually very meticulousness we are seeing in the from the beginning in the making of the pamphlet, making of the program, taking the topics, taking the speakers, then even the panelists, everything is so good and so meticulously planned. So congratulations, Monica. And today's topic, the twice the trouble, this multiple gestation, actually it is uh, every obstetrician actually face this problem, and that's why I am seeing a lot of gatherings to just listen to Charmila, Sita, and Divya. So congratulations for this topic also. My respected madam, Mandakini madam, she's our own from Ujjain and Indore. So my regards to madam Sumitra Didi, I think she couldn't join. Then Dr. Sonal Kotawala and Dr. Rakhi, they are actually the very lovely people and special guest. And all our 4 girls, I want to appreciate them because last year also I saw working with you, Purva, Nandini, Shweta, and Shikha. So thank you all for just coordinating well. Then Dr. Sita, I don't want to say so much. I just want to listen you. This topic is very apt and you are the apt speaker for that topic. Then Charmila and Dr. Divya Singh, all the chairpersons and all the panelists. And I just want to just say that these are the topics everyone wants to listen. Everyone, just like Madam said, Mandakini Madam, though this is the era of the modern technologies, still we are actually facing this problem. The sonography is saying singleton pregnancy from the remote areas, and there are twin pregnancies, and still we are not saying, and the patients are not even suing to anyone, not suing to the doctor also, because they belong to the tribal areas where they are actually just to do the formality of the sonography or investigation. They are going for that, and they are coming with, they have twice I have seen they have written twin pregnancy, and these were the triplets. So these are this is everywhere we cannot say this investigation part is actually helpful. There are so many areas in our own India, in the tribal areas, where they are not actually catching all the facilities. So still, our as a gynecologist, our primary part to just palpate and just hear the how many times we are taking the fetal heart from every part of the abdomen. It is actually also important. So that's not wasting so much of the time, and keen to listen Sita and Divya and Charmila. And best of luck.
Thank you. Thank you so much, Dr. Jyoti. Thank you so much
Thank
for
you.
your
Thank you, Dr. Jyoti. Yeah.
and for your warm words. And I'm indeed very excited to listen to the lectures. But before that, we have a very pleasant duty to welcome our special guests. Our special guests are some people who are very special to us, though they might not be important post-wise, but they give a lot of weight to the program simply by their presence. So I have got a very dear senior in front of me, Dr. Sonal Kotadawala from Ahmedabad. Can I have Madam CV? Dr. Sonal Kotadawala is a senior gynecologist and ART specialist at Kotadawala Women's Clinic in Ahmedabad. She is a very keen endoscopic surgeon. Way back in 2006, when people were just starting to use the trocars and the scopes, she's also been state coordinator for contraceptive awareness in the Foxy Family Welfare Committee in 2010. She takes a keen interest in school and college health education, has got several paper presentations in national and state conferences, is an avid, author, has written journal articles, published chapters, and has held wonderful conferences like AICOG 2017, Yuva Foxy, and HRP Con 2019. Dr. Sonal ma'am, I'm so thankful to you for joining, and we would like to have a few words from you, madam.
Thank you, Dr. Monica. In fact, I can see that, my biodata, my CV is like I'm a consultant. That's it. And I frankly enjoy it because 2 people in the same family is a bit difficult. Somebody has to, Dr. Sita Pal is laughing, but, somebody has to be at home.
It's very true.
Running both the hospitals, I know. But anyway, thanks a lot. And first of all, I want to thank Dr. Monica and Dr. Rakhi Bajpai, and along with that, both societies, Bhopal and Jabalpur societies, colleagues for inviting me to this webinar. I acknowledge the presence of Madam Mandakini Meg, who is an inspiration for all of us, and her talk really proved that. Along with that, guest of honor, Dr. Sunita Yadav and Dr. Jyoti Banglowala, they are also, really very, what do we say? Okay, they are role models for all of us. And I compliment Dr. Monica and Dr. Randir for selecting this topic of multifetal pregnancies, because we know as clinicians, and I'm also in the IVF, so we know that we are now going for single embryo transfer most of the times to avoid all the complications of twin. But what about the other pro-fertility treatment? All other our pro-fertility treatments might end up, our routine IUIs, even clomiphene citrate or this fertility treatments, they all might end up with multifetal pregnancies. And this is the right topic to choose, which is need of the hour. We have stalwarts like Dr. Sita Pal, who is a renowned fetal medicine expert, and we would be really happy to listen to her when she shares her expertise on this various issues which are to be dealt with. Also, Dr. Divya, who will deal with the challenges of anomalies. And I think the panel under the able guidance of Dr. Chamila will be covering the practical management points, which are really important for all practicing obstetricians. So looking forward to this academic fest. Thank you again.
Thank you. Thank you, Sonal ma'am. And we'll be really delighted if you could stay on in the program. And I move on to our guest of special guest for tonight, today evening, that is Dr. Rakhi Bajpai ma'am, who is president of Jabalpur OBGY Society. I welcome Dr. Rakhi Bajpai. She has taken over as president of a very dynamic society of Jabalpur, which is very vibrant, colorful, and with all sorts of active members who are good in academics, cultural activities, everything. So Madam is also a fertility specialist and a laparoscopic surgeon. She is working in Sai Test Tube Baby and Laparoscopy Center in Jabalpur, MP. Madam is life member of all prominent associations, medical associations of India. She has now taken over as president till the year 2026. She has been very active and been felicitated by MP government for providing voluntary services in National PM SMA Abhiyan, as well as recipient of Bharat Excellence Award. Her biography is there in Asian American Who's Who, and she has had publications which have appeared in Asian Journal of OBGY and IMA Journal. She is an avid social worker, active in rural medical camps, free medical camps, blood donation camps, environment-friendly camps, and also done a lot of tree plantation. We saw it in the recent World Environment Day, how active Jabalpur Society was in her leadership. We welcome you, Rakhi ma'am. We'd like to have a few words from you, madam. मैडम आप म्यूटेड हैं. मैडम प्लीज अनम्यूट.
Thank you so much, Monica madam, for such nice introduction. And I really feel proud to be part of this very exciting CME on multifetal gestation, madam. And I met only once physically with you, and I have become the fan of you. The way we met, it was really very amazing. So in this CME, I welcome Madam Mandakini Singh, madam, our chief guest, and our guest of honor, Dr. Sumitra Yadav, madam, Dr. Jyoti Banglowala, madam, and Dr. Sonal Kodawala, madam. And this multifetal gestation, whenever it comes with many complexities, not only in mother, but also in fetus. So because of using ovulating agents, this problem is increasing day by day. And we have also, as madam has already said, we have changed our protocols for embryo transfer. We are now doing single or double embryo transfers to make it to mitigate these risks, madam. So Madam, I congratulate not only you, but to Dr. Saab also, Randhir sir, for organizing this very exciting CME and making me part of it. And I wish you all the best for your future endeavors.
Yes, ma'am.
Over
Thank you.
to you, madam.
Yes, sorry for the disturbance, man. Studio, could you please mute everyone? I think the faculty link has been shared by mistake, Shweta. Shweta Purva, I think the faculty link has been shared. Doesn't matter. Studio can mute the participants except the speaker. Thank you so
Okay.
much, Rati ma'am. Thank you so much for joining
Thank you,
us
sir. Thank you so
and
much.
giving us the opportunity to collaborate with Jabalpur OBGY Society. I would like to thank Dr. Randhir, who is my co-convener, and we have listened to him. So now we move on to the four brilliant stars of my society and Bhopal. Dr. Purva Bhatkur, who is Assistant Professor, GMC Bhopal, very active in academics, very active in research, a very loving mother, very conscientious clinician, a very hard worker, always up and about. And if it's anybody I want to call early in the morning or late at night, it's Purva. Thank you, Purva.
Thank you so much, ma'am.
Next, I would like to welcome Shweta Agarwal. So if Purva is 19, then Shweta is 20. So Shweta is another person. She will pick your phone in the first ring. Sometimes the first ring is also not over. She will pick the phone, and that is so reassuring. When you are panicky, when your things are going wrong, when some trouble is coming, I mean, they are like the godsend. So Shweta is also very dynamic gynecologist, young gynecologist, and happy anniversary today, Shweta, to you. She's completed 5 years of a beautiful married life today, and she is a very active worker in BOGS, in ISAR, and she's got a long way to go. All the best, Shweta.
Thank
So thank you so much. And now I hand over the first session to Shweta Agarwal to welcome Sita ma'am.
The first session is the art of managing multiples, fetal medicine considerations. And to chair the session, we have Dr. Hitendra Somani, sir. Sir is director at Nirmal IVF Test Tube Within Advanced Laparoscopy Center, Bhavnagar. Sir has held the position of Secretary IFS Gujarat Chapter, past Joint Secretary IFS, and past President of Bhavnagar Obstetric and Gynecology Society. Sir has been awarded as FICOG at AICOG Conference in 2015, Best Paper Presentation at Yuva ISAR, and Divya Bhaskar 2018 Eminence Award. And Sir has also received Atmanirbhar Award at Gandhinagar in 2021. And Sir has done many publications. Sir is invited faculty nationally and state level. We welcome you, sir.
Thank you. Thank you.
Next, we have Dr. Bharti Sahu, ma'am. Ma'am is Associate Professor Netaji Subhash Chandra Medical College, Jabalpur. Ma'am has done international research and she awarded as International Research Star Award by ISS and International Research Award Congress. Ma'am has held the position of Vice President, Jabalpur Obstetric and Gynecology Society, and Treasurer President, Jabalpur OBGY Society. And ma'am is affiliated to IMA, IMS. We welcome you, ma'am. Dr. Prerna Krishnan, madam, couldn't join. So I hand over the session to Dr. Hitendra, sir, for introducing Dr. Sita, madam.
Good evening. My special thanks to Dr. Monica, madam, and Dr. Randhir, sir, for giving me this opportunity. And I feel deeply honored to introduce Dr. Sita Rammurthy Pal. She is a consultant fetal medicine and genetics, Apollo Hospital and Ankur Fertility and Fetal Medicine Center, Kolkata. Madam is Honorary Joint Secretary, Bengal OBGY Society. She is the chairperson of Genetics and Fetal Medicine Committee, FOXY 2326. She is the president of Society of Fetal Medicine, Kolkata 2426. She is a joint secretary of ISOPAB Kolkata chapter. She is the examiner of MRCOG Part 3. She is member National Board Specialist Committee of Maternal and Fetal Medicine. Madam is going to talk about art of managing multiples, the fetal medicine consideration. Over to you, madam. Thank you.
Thank you. Thank you so much, Dr. Somani, for your kind words and your kind introduction. I'll just share my screen. Until I share my screen, I think I must take this opportunity to congratulate and thank
a dear friend Monica, who has been so consistent and all her webinars, one after another. She webs out webinars with flawless perfection and beautiful topics. So thank you, Monica, for that. I've been watching your space with perfection. Series is very much to perfection. With her, Dr. Randir, of course. Thank you, Dr. Randir, for this opportunity. And of course, it's a big warm greetings and my namaste to Dr. Mandakini Meg, madam, as you all have rightly said. She's always there for us with a helping hand and has guided immensely in all our problems and given us solutions. And congratulations, madam, for achieving this very, very honorable post of AMWI president, of global president. And thank you to Dr. Sumitra Yadav, who has not been able to join. And of course, my greetings to Dr. Jyoti Banglowala, who's also been very in the forefront with all her activities in her committee. She's doing a fantastic job. So good to be as a co-chairperson with her. And of course, the Jabalpur Society, who had been there a couple of years ago, last year for their fetus day. So we have our friends in Jabalpur Society, Dr. Deepti, Dr. Deepankar Banerjee. So it's a beautiful place there. And of course, Dr. Rakhi Vajpayee and the other chairperson and the other special guest of Dr. Sonal Kordawala, who I must say that she has herself a brilliant endoscopic surgeon and an upcoming brilliant fetal medicine specialist in her family as well. So it's wonderful to see that. And thank you to all your 4 coordinators. I see they are brilliant in what they are doing. So best wishes to them. So without further ado, I'll start my topic of art of managing multiple pregnancies. Is my slide visible?
Not yet. Madam, I must personally thank you because Madam was, I requested Madam last minute and she agreed for this talk. Madam, I'm so thankful to you. Madam has always, been a very big supporter. So, Madam and Bhaskar sir both. I can't decide between
No.
them sometimes. But
you can't see my slides, Monica?
Not yet, Madam. Not yet.
Oh.
It's coming. Dr. Sita has started screen sharing.
1 second. I'll just.
Are you in a network area, ma'am?
Yeah. Network is absolutely fine. Let
Right.
me just. 1 second. I initially had shared it.
You can take your time, ma'am.
Yeah.
In the meantime, Dr. Purva, you can place a phone call to Dr. Divya Singh and Charmila,
Okay.
madam.
Yeah. Can you see?
Yes, ma'am.
Okay, just 1 second. Yeah. I'll just put it in slideshow.
Right.
Okay. So we're going to be talking about art of managing multiple pregnancy, which is an art actually, but we will see how we can make it scientifically, possible and with evidence based for our patients. So that's me for you, and thank you once again. So as we heard earlier from Dr. Mandakini Meg, madam, as well, and from Dr. Sonal Kordawala and Dr. Rakhi Vajpayee, that the incidence of multiple fetal pregnancy is rising with advanced maternal age and with assisted reproductive techniques, but there has been a modest decrease with single embryo transfer. And with twins, it is especially most common because it has increased by 70% from 1980, but eventually over the years, it has decreased to about 32 it has increased, to 32 per 1,000 live births. So, with ART, though there is a decrease, we are seeing an increase in multiple pregnancies. It's not only because of ART, it's also because of the ovulation inducing drugs, which we give sometimes, and that causes multifetal pregnancy. Now, in that, 1/3 of all twin pregnancies are monochorionic. And of course, When this happens, there is risk for the mother and the fetus. There is increased risk of, especially for the fetus, there is a risk of perinatal mortality, morbidity due to preterm birth, growth restriction, complications, which we will see as we go on. And of course, we must not forget the mother here, that there is a risk of maternal complications, especially if she's elderly with comorbidities like preeclampsia, PPH, and all this leading to iatrogenic preterm delivery, which itself is a big problem for the fetus. So you must remember that all monochorionic twins are monozygotic, so they can be dizygotic or monozygotic, that is zygosity. All dizygotic pregnancies are dichorionic, but all monozygotic pregnancies can be dizygotic or monochorionic or dichorionic. And so that is why all monochorionic twins are monozygotic and 6 sort of dichorionic twins are dizygotic. Okay. So this will typically depend upon when the splitting occurs. So as we say, whenever there is a report of twins, as our Professor Kypris Nicolaides says, whenever any report comes of twins, you should not be accepting the report unless it mentions about chorionicity. So there is no diagnosis of twins. It is only either monochorionic twins or dichorionic twins. So it all depends upon when the cleavage occurs. If it occurs very early, then it is dichorionic diamniotic with 2 separate placenta or 1 fused placenta. But if the cleavage occurs later, then there will be 1 placenta with 2 sacs, that is a monochorionic diamniotic. Then if it occurs later from 8 to 13, it is monochorionic, monoamniotic, where the dividing membrane is not seen. And of course, if it occurs very late, we all know there is a risk of conjoined twins, where it can be attached at any point in their body. So with twins, the risk increases in compared to singletons, but the difference is also there in terms of monochorionic twins, where the risk of miscarriage increases, the risk of perinatal death more than 23 weeks increases, and everything is doubled in monochorionic twins, the growth restriction, the preterm delivery, and also the risk of major defects. Now, I know we talk about the fetus, but as I said before that, we must consider the mother, and the whole thing should be taken as in a holistic view, and the whole thing should be taken into perspective. So you have a multidisciplinary team, which is most important here. The obstetrician, who's the single point of contact, the fetal medicine specialist, and the neonatologist involved at the right time. You have them referrals to dietitians, psychologists, and physiotherapists. And it is important to understand that these women often come from far-off places, so you have to minimize the hospital visits, combine the antenatal and scan appointments as much as possible, so everything can happen in one go. And of course, the maternal screening, I'm not talking much about it, which might be covered in the panel. But the role of preeclampsia screening is important because they are at high risk of preeclampsia, but it remains controversial because the uterine artery PIs are actually lower in twins, and there is not enough evidence to say that aspirin will be really good or not. But when we come to fetal health, there are a lot of considerations. It starts off with the dating of the pregnancy, which is very, very important for every pregnancy, especially in twins. And if one message you need to take from this for fetal consideration in multiple pregnancy is chorionicity, chorionicity, chorionicity. You cannot go without it, because from the beginning to the end, that will tell you, guide you as to how to manage this pregnancy, what are the risk factors, and how to take it forward. How do you monitor? Timing, frequency will again depend upon the chorionicity. The screening and diagnosis for aneuploidy, screening for structural abnormalities, discordant growth, preterm birth, every aspect becomes complicated in multiple pregnancies. And again, I'm reiterating that everything depends on the chorionicity. You have issues regarding to monochorionic pregnancies, and if there is a single fetal demise, again, that will depend upon the chorionicity. So we all go by our Bible, which is our ISUOG Bible. And in fact, the latest guidelines on multiple pregnancy has come up in 2025. So I would urge all of you all to just go through it. And in current era, ultrasound has replaced our stethoscope. So we should, especially in multiple pregnancies, though these women may not have an access, it is impossible to actually clinically estimate what is going on. So ultrasound becomes the most important parameter in guiding us what we can do. So when you come to dating, it has to be ideally dated when the crown rump length is between 45 and 84. Yes, in ART pregnancies, they do tend to have, scans earlier to just check what is the viability and everything. But whatever dating has been done, I think it should be reconfirmed at the combined first trimester, early first trimester morphology scan, as we would call it. So in pregnancies conceived spontaneously, the larger of the two CRLs should be used to estimate the gestational age. Because if we take the smaller one, if by chance that smaller one is actually having a problem, you would be wrongly dating the pregnancy. So the larger of the two CRLs should be taken into consideration. And of course, for Yati pregnancies, it will depend upon the rate of transfer. Of course, if it is blastocyst transfer, it is day 3 or day 5, depending on that. And all your machines can actually tell you what is the expected date when you put the date of transfer. But if it is day 3 or day 5, you subtract accordingly 3 or 5 days. And again, as I said, chronicity should be determined between, the best time is between 11 to 13 weeks of gestation. You can determine amnioticity early on when you can see 2 yolk sacs, it is, diamniotic. But sometimes the membrane might not be seen earlier so well. So you have to see, especially in the combined first trimester scan, you look at the membrane thickness at the site of insertion of amniotic membrane. And whatever you do, always keep an image, because if she goes somewhere else for her pregnancy or delivery, one look at that image, even if it is not reported, we will know that this is a monochorionic or dichorionic. So in DCDA placentation, the fetus is actually separated, as you can see here, by a thick layer of fused membranes between two amniotic layers. So you will have a white lambda or a full lambda sign, which is typical of dichorionic pregnancy, whereas in monochorionic pregnancies you'll have a thin, there is no intervening chorionic membrane, so you have called what is known as an T sign or an empty lambda or a black lambda sign, because this space is actually empty, and that is why more than T sign we call it as an empty lambda sign, where you don't see the intervening thick layer with the two amniotic layers. You don't see the full lambda sign. Sometimes you have the placental masses, which we can see. Of course, if there are two placentas, anterior and posterior, you know for sure that this is a dichorionic placentation. So here you will typically see that, and the dictum in any type of pregnancies, especially in ART pregnancy, is that you start with 1, you always look for 2, you see 2, you look for 3. So as Dr. Jyoti was saying, sometimes you see patients coming up with twins, and then so it is important you have to assess the complete uterus, because one might be slightly small or hiding behind. So it is important to make sure you're not missing these number of multiples. Again, as I said, chorionicity, if it is not possible to determine, use transvaginal ultrasound, because sometimes that dividing membrane is so thin, you may not be able to, if there is a high BMI patient, you may not be able to see it abdominally. So transvaginal has actually become a norm in multiple pregnancies for us, be it first trimester, in the second trimester for cervical length, or even for looking at anomalies. So you must confirm this chorionicity also by a transvaginal ultrasound. But for any reason, if you're still uncertain, you must continue the pregnancy as a monochorionic diamniotic and label as that. Site of cord insertion should also be noted and document. If you have actually confirmed that there is no intervening membrane and it's a monochorionic monoamniotic twins, they should be referred to a tertiary center right from the beginning. And of course, in these pregnancies, you can demonstrate the cord entanglement, which is almost always universal in monochorionic monoamniotic. So you're typically again reiterating the fact that earlier on you can see 2 sacs like this with 2 amnion. You're sure that it is a diamniotic pregnancy, and further on, when you will see the thick lambda sign or the T sign, and of course in monochorionic monoamniotic, you will see this entangled cord mass, which actually clinches the diagnosis. So typically you will have all these various combinations depending on whether they're twins or triplets, trichorionic triamniotic, dichorionic triamniotic, monochorionic triamniotic triplets, monochorionic monoamniotic triplets. These are different permutations and combinations, but usually we tend to see up to TCTA triplets and sometimes very rarely dichorionic diamniotic triplets as well. So labeling of twins, again, a very, very important issue is because when you label the twins, you know which fetus you're following. And if you put it in your notes, this is what I'm seeing as twin A and this is what as twin B. If she goes to a different person later on, or even when she delivers, you know exactly which fetus you're following. So they should follow a structured, reliable, and consistent strategy, and it should be documented whenever you are doing the scan. And you must give as much information as possible. Usually earlier on in pregnancies, you will find that they are, positioned on above and below each other. But over the gestation advances, you will see once it takes a longitudinal lie, it becomes left and right, and you take you label it as in the maternal left with placenta anterior with marginal cord insertion, and you mention all these points rather than just which is just by saying this is close to the os and that is why that is twin A. That should not be the case, because with earlier on it might be the case, but later on in the second trimester they might change the position. And also it is important as you label, suppose you're labeling twin A and twin A has subsequently gone on to develop FGR. When you're monitoring these fetuses antenatally by CTG, it is important to know that CTG is monitoring that twin and you're looking at the twin which is growth restricted. So that is also important in labeling when you're not only for ultrasound, even when you're doing the CTG. And of course, during delivery, sometimes rarely that can happen is what you're mentioning as twin B might be at your placenta, at your site of incision. So your twin B, which you have labeled in the ultrasound, might be the twin A that you have delivered by cesarean section. So that is called a perinatal switch phenomenon, which can happen and which you have to be knowing about. So the irony of ART pregnancies is you put more and then you want to reduce to 1 or 2. So that is the irony of artificial reproductive techniques. But there is important that if there are triplets, we know that there are risks of preterm delivery and problems. So generally, if there is a triplets, if the patient agrees to and with proper counseling, you can reduce to twins. Sometimes we get requests nowadays of even twins getting reduced to singletons. It depends upon what the situation is. Suppose the mother family already has one single baby child who is fine, and now she's 42 with ART with comorbidities. We get such requests. So it depends. Adequate counseling is very important, because you might reduce one twin and we don't know at that point if the other twin is harboring some anomaly, an evolving anomaly. So you have to counsel them adequately. But generally, when we screen for reduction, you take the one which is smaller, the one which has a larger entity, or sometimes some fetuses which have an abnormality. But otherwise, usually whichever is closest to the fundus, you would reduce, because that would not cause a miscarriage if you do it something which is very close to the cervical loss. Yes, with TCTA triplets, when it is, the chorionicity is different, you can inject KCL that will not harm the fetuses. So you can just reduce one and the other two will be fine in triplets. But if it's a triplets with a monochorionic pair, you can't use KCL, because if you want to keep the she wants to reduce the twins and you want to reduce the reduce the keep the monochorionic pair, then that has complications. And so if you want to reduce one monochorionic pair, you can't do it with KCL, because that will affect the other fetus. So you will have to use other methods like laser and RFA. But it's important to also interesting to note that some of these fetuses who have had reduction from monochorionic pair, and we call them again later to see the other pair is there or not. Sometimes they have said, no, we'll keep singleton, we'll reduce the monochorionic pair. And then they come back, they get lost to follow up, and they come back later on with both the twins going on fine. So there is a growing theory which says that if this reduction happens at 12 weeks, it might not affect the other monochorionic pair. But generally, monochorionic pair, you will not use KCL, you would use a laser or radiofrequency ablation. Coming to the guidance as to how to manage these pregnancies, NICE has come up, even ISUOG has come up, and it is very, very clearly said that they need once you do your early first trimester ultrasound, doing all your markers, then you need to follow them up depending on the chorionicity. So for for dichorionic twins, you will follow them every 4 weekly. That is at 20 weeks, 24 weeks, 28 weeks, 32 weeks. And at every ultrasound, you will look at the biometry, look at the deepest vertical pool. Here is somewhere you don't use the AFI, you only look at the Leica volume by the deepest vertical pool. But because monochorionic twins have incidence of complications, you can't wait till 20 weeks. You have to start scanning them from 16 weeks, and you scan them every 2 weeks. And then you not only use the biometry, you also look at the Dopplers, because these Doppler abnormalities are what will pick up problems. So when we talk about aneuploidy, it's again important to say that it is slightly different in terms of twins. You can do it So it is important to have a pre and post test counseling. You can do your combined FTS, which includes your focal translucency, free beta hCG, and PAPE, where the detection rate is around 88 to 90%. But in cases of vanishing twin, if there is still a measurable fetal pole, that fetal pole obviously could skew your results and will give you false positive results. So it could be because that fetus was aneuploidic, and that's why it sort of succumbed on its own. And so you should not be using any biochemical markers. You should only be using NT alone in combination with maternal age. So when it comes to screening for aneuploidy, because monochorionic twins they have the same genetic composition, you take an average of NT and then you take the average of the calculated risks. Whereas in dichorionic twins, they are individual twins with separate genetic potentials or separate genetic mark their compositions. So you will have an individual risk. So again, it is important to look at the report when you get the report of aneuploidy to check whether they have actually seen and remarked as dichorionic or monochorionic, because the risks would be different in a dichorionic twins. And of course, sometimes you will see that in monochorionic twins, they have chances of having increased NT, but usually the increased NT, as we normally say in singletons, is because of any aneuploidy or because of cardiac defects or any other single gene disorders. In monochorionic twins, usually the discordant NT is because of vascular anastomosis that they have and fluid imbalance, which causes this increased NT. Again, it is important to remember that in higher order multiples, we don't use the biochemical markers. We only use NT and maternal age, and also in cases of fetal reduction, the same thing as would happen, because it's a non-viable embryo or fetus that is lying there. What about NIPS? Yes, there were earlier on studies which said that the detection rate was 98%, good, modest sensitivity for trisomy 18 and 13. Median fetal fraction, yes, is sometimes lower, and they said dizygotic lower fetal fraction could be used. But recently, there has been a study in 2021 where Asma Khalil's group has said that they do have a higher fetal fraction. The failure rate was reassuringly very low. And so combined cell-free DNA testing can be considered to be the most accurate test for trisomy 21 in twin pregnancies. And in fact, they have suggested that to be as a primary screening test in twins for trisomy 21. Of course, with 18 and 13, it is not as good, but for trisomy 21, I think if you have, other problems in terms of biochemical markers, but in vanishing twin, you will still not use an NIPT because that is still a biochemical marker. But if you are willing, if the patient is willing, you can use NIPS as the first line screening test. So when vanishing twin, as I said, it's important to know whether there is an empty second sac, then you can use the combined test. But if there is a second sac containing a non-viable fetus, it will skew your results, which is better to avoid. And here they have said that instead of using PAPE, because that is the one that gets affected, if your lab is able to give you the combined screening test with only free beta hCG, you can do that and you will get a result. But generally, the advice is that if you have a non-viable fetal pole or after reduction, you should not be doing any biochemical estimation at least for the next 15 weeks. So if you have had that and then you want to do some screening in the late second trimester, you could still do an NIPS, because the NIPS can be done even after later. What about diagnostic considerations in these fetuses, in twins? Usually you prefer CVS, but again, as I said, mapping is very, very essential, because what you have seen as this fetus, suppose you've done an amniocentesis for a particular fetus, and that fetus turns out to be trisomy 21. So it should be the same person who is doing the mapping and who's doing the reduction, because it should be performed by an operator with skills to perform selective termination as well, because the same operator will understand which one he or she had taken the sample. So important to label the samples correctly. And of course, you can use either a single or double entry depending on that. But usually when we have a problem in one twin, if it's dichorionic, we usually tend to sample both the sacs, because we want to make sure that the one, if it comes abnormal, the other is also fine and we're not missing anything there. Screening for structural anomalies, I'm not going to go so much into detail because I'm sure Dr. Divya will do a beautiful job on this. But generally, yes, we do a second trimester scan followed up by cardiac screening, especially in cases of monochorionic twins and triplets. Of course, again, it will depend on whether they have it's a dichorionic, where if there is an abnormality, you can put KCL, but if it is monochorionic, it will depend upon what the abnormality is and whether it is lethal or non-lethal. And again, you cannot use KCL or you will do a selective fetal reduction by bipolar. Okay. Screening for preterm birth. Yes, preterm birth is a major concern even in twin pregnancies, in multiple pregnancies. So it is important to screen them in the second trimester. So generally, what we do is, and that is why we need to do a transvaginal scan at every point, because even later on at 28 weeks, you will have the risk of having spontaneous preterm birth. So the typically transvaginal ultrasound from 16 weeks onwards to see, and the same measurements happen as to whether less than 2.5 centimeter will be at high risk. We don't use any other methods like fetal fibronectin. And of course, there's always a debatable role of bed rest, progesterone therapy, and cervical circulage. But screening should always be done by transvaginal scan looking for short cervix. Screening for FGR, we look at that from 16 weeks onwards. For MCT and 24 weeks onwards, we look at that. Though the people have suggested twin-specific charts to be used, which may be better, but at this point in time, we are using the same singleton charts, and whatever charts you're using, you will use the same charts for every time you measure. And as I said, a discordant CRL of more than 10% can be a marker of selective FGR when you're initially marking it. And that is why you don't take the small CRL as for dating. And in twins, we don't use the amniotic fluid index. We measure the deepest vertical pocket taken on either side of the amniotic membrane. These things are important when we look at cord insertion, as I said. So because if there is a well-element cord insertion, especially in cases of monochorionic twins, it will indicate unequal sharing, and that will increase your risk of FGR. So it is important to mention that there is a well-ementous cord insertion or marginal cord insertion. So this is the criteria for selective growth restriction in twin pregnancy, same as in terms of singleton, where there's a solitary criteria of less than 3rd centile, or there is an expected fetal weight of less than 10 centile. More importantly, discordance between the twins of more than 25%. So generally, whenever the discordance starts happening between 18 to 20%, we tend to keep a closer eye because we know this baby is going in for growth restriction. But of course, there are contributory factors like umbilical artery PI above the 95th centile that will tell you whether this is a selective growth restriction, can be either in dichorionic or monochorionic. In dichorionic, it is the same as in singleton pregnancies, but in monochorionic, it depends because of the vascular anastomosis. It is classified depending on the abnormalities of the diastolic velocity of the umbilical artery, and it is typically as type 1, type 2, and type 3. Where there is increased PI absent and intermittent absent or reversed in type 3. And 2 and 3 are associated with higher risk of IUD and neurological sequelae. So again, the question here is to diagnose the time at which these abnormalities occur, and then if it is too premature, to decide whether to sacrifice the other growth restricted twin in monochorionic twins, because if you wait till IUD has occurred, then you've lost one and you're compromising the other one as well. Of course, again, here the management options include conservative early delivery or laser ablation or bipolar cord occlusion. So in growth restriction, you have early onset less than 24 weeks, not like compared to the singletons, and late onset is more than 24 weeks, and you can have Dopplers like in stage 1, umbilical artery Doppler. This is for monochorionic twins, of course. Stage 1, where there is umbilical artery Dopplers. Stage 2, with umbilical persistent absent end diastolic flow. Stage 3 is abnormal. Stage 2B is intermittent absent end diastolic flow. Stage 3 is abnormal ductus venosus Dopplers. Stage 4 is superimposed TS, and stage 5 is intrauterine demise. So when you have SFGR in monochorionic twins, you can have it with TTS or without TTS. So that is, these things can coexist, and that is what the fetal, it's important to refer them to the fetal medicine specialist. Now, when we talk about monochorionics, as I said, these are specific complications because they have this unique existence of vascular placental anastomosis that are universal and connect fetal circulation of both twins, right? So you have different complications like TTTS, TRAPS, twin anemia, polycythemia sequence, and single intrauterine demise. So if the transfusion, that is if it is unbalanced, you will have TTTS and TAPS. If there is discordant placental territories, that is, as I said, melamentous or marginal, you will have selective growth restriction. If it is a single fetal demise, usually what happens is an acute transfusion and problems causing demise of the other twin, and of course discordant malformations because of discordant anomalies or conjoined twins. So Leica discordance in monochorionic is usually depending upon what you have. So any Oli-Poly sequence will have many, which means that to diagnose TTTS, you should have an oligopoly sequence. You cannot have TTTS without this. So if the Leica volume is normal and there is oligohydramnios, you must make sure that there is no growth restriction, or if she has ruptured her membranes. But if there is normal and polyhydramnios, it is important to rule out anomalies in these fetuses. And so you have to look at them closely to see whether there are any evolving problems. And the diagnosis for Oli-Poly would be less than 2 and more than 8 centimeters. So TTTS affects 10 to 15% of monochorionic twins. Early diagnosis is essential, which may allow intervention with fetoscopic laser ablation, where you coagulate laser treatment of all these communicating vessels and you dichorionize the twins. Early prediction has been done, but usually the best predictors are NP more than 95th centile and ductus venosus reversal, which has a good relative risk of 21. So I'm not going into these details, but yes, in TTT stage 1, you can have an expectant management. Stage 2 and 3, you can have a laser selective laser photocoagulation. Stage 3, it's too late. You just do serial amnioreduction. And stage 4, you have to individualize whether you have to do anything at all. TAPS is usually the presence of arteriovenous anastomosis, which causes polycythemia in one and anemia in the other. It can happen spontaneously or it can happen after post-laser treatment. Usually they tend to have a conservative management, but sometimes you can ablate or even give intra-uterine transfusions for the anemic twin with partial exchange transfusion for the polycythemic twin. Single IUD for a dichorionic twins is very, very, safe, because you can ignore the other twin and monitor the ongoing twin and make sure that the other twin has no problems. But in cases of monochorionic twins, it's important because that can cause death of co-twin and especially neurodevelopment impairment. Once the co-twin demise has already occurred, there is no point delivering that twin because the damage is already done. What you have to do is counsel them and maybe do an MRI late after 4 weeks to see if there are any neurological sequelae in the surviving twin. This is in case of monochorionics. TRAP is very, very rare complication of monochorionics. This was a monochorionic diamniotic triplets, where this was a TRAP sequence where usually it happens as a presence of an cardiac mass which is perfused by a normal twin. This, because the pump occurs in a retrograde fashion, and that is why only part of the fetus is developed, the head doesn't form, so it's a cardiac mass, the lower limbs and the abdomen gets developed. So here it depends upon how big, whether the circulation is still there, whether the TRAP sequence is actually increasing in size, and depending on that, you use methods. Some of them they resolve on their own, but if it is not, then you have to use cord coagulation and photocoagulation of the anastomosis. And regarding when you have managed all these complications, when you come to the mode of delivery, yes, in DCDA twins, you can take them up if it's uncomplicated to 38 weeks. MCDA twins with no complications, you can go on to 37 weeks. With Momo, yes, 34 weeks. So generally, you have to, do a cesarean section for Momo twins and triplets. Whatever it is, if they are going into labor, you need to monitor them closely in labor and use an intrapartum monitoring, and consider CS of vaginal birth if not second baby is not achieved within 20 minutes. So my take-home messages is for that every trimester is important for these multiple pregnancies. First trimester, you date, you determine the chorionicity, you do your NIPS as a combined FTS. Second trimester, you do an anatomy scan or fetal echo. 2 weekly or 4 weekly, depending on the chorionicity, you do a growth scan. Discuss your mode of delivery around 32 weeks and deliver them by 36 to 37 weeks or 38 weeks in dichorionic. Please seek fetal medicine help for complications, because perinatal outcomes have improved with interventions, both invasive, non-invasive, monitoring them. Advances in neonatal care has also improved. We can take babies of 1 kilo at home, but you must remember that these multiple pregnancies are at high risk. You have to detect these risk factors antenatally and timely refer them to tertiary center with neonatal backup. But the most important message here again is that to avoid iatrogenic prematurity. Just because they have reached 34 weeks, everything is fine. Don't deliver them prematurely. That causes all the more problems. There are research areas to use twin-specific charts and medical interventions. And of course, all these are measures to reduce admission to neonatal units. So the art of managing the multiple pregnancies is actually a delicate balance of science and sensitivity. It shouldn't be taken as twice the trouble, because we should aim to give the parents twice the joy and make this experience a memorable one for them. Thank you so much for your patient hearing. Thank you.
Thank you so much, ma'am, for the beautiful talk. Very, very lovely talk and covered everything. Chairperson's comments, please. So, Mani sir.
Excellent talk, madam.
Thank you. Thank you.
Very informative, very informative.
Yeah, there is so much to cover in the fetus, especially in multiples as monochorionic.
You covered so much, ma'am.
Yeah, I hope
I have a question. With the permission of chair, I'd like to ask
Yes.
to you. Thank you, sir. Madam, in IVF, when we transfer two embryos and
Yeah.
we get DCDA twins, you have mentioned that the blastocyst, when it divides after implantation on day 1 to 3, it gives rise to DCDA twins.
Yeah.
So when two embryos give rise to two separate sacs and two separate implantations happen, will that also be a category of DCDA twins, or do you find a difference in those twins and the ones which divide from blastocyst?
No, they behave the same, dichorionic twins.
Ma'am, when you see a twin pregnancy, DCDA.
So what you're trying to say, if you've given two embryos, you've transferred two embryos, right?
Yes, and both of them have implanted, ma'am.
Yeah, so that would behave like a typical dichorionic pregnancies only. Unless they have divided again inside, we don't know the splitting has occurred or not.
Yeah. One of them might divide again and give rise to another DCDA.
Absolutely possible.
Right. Thank you, ma'am. Thank you. So I think we can move on to session 2. If there are any further questions, then you can put them either in the chat box or unmute yourself and ask. Dr. Divya is also there. And thank you so much, Sita ma'am, for the very comprehensive and lucid deliberation. And it's always a pleasure to have you in the Synergy Club.
Thank you so much for the opportunity. Thank you.
So,
to hear Dr. Divya Singh.
Before we start the second session, I want to give my respect and regards to a very senior obstetrician gynecologist, senior member of FOXI, who is amongst us from Jabalpur OBGY Society, Dr. Shashi Khare Madam. Madam is past dean of NSCB Medical College, Jabalpur, and we are honored to have her presence in the Synergy Academic Club. We also acknowledge with regard Dr. Suman Sinha Madam, Chairperson Vaginal Surgery Committee, as a part of the Synergy Academic Club. Thank you, madams.
Now moving onwards to session 2, we have two peas in a pod, unraveling congenital anomalies in twins. And we have speaker Dr. Divya Singh, and we have chairperson Dr. Monica Singh ma'am. Madam is president-elect Bhopal Obs and Gynae Society, founder president ISOPAP chapter of Bhopal, national executive member SR, and ma'am has held many important posts, like she has been the vice president of OBGY Society, and she is convener of webinar series SR Perfection, FOXI Symbiosis and Synergy Academy. We welcome you, ma'am. Ma'am, over to you, ma'am.
Okay, I'm the only chairperson today. No, Tasneem madam is there?
Yeah, I'm here, ma'am.
Tasneem madam is there, please.
Dr. Tasneem Shah, madam. Madam is HOD Department of Manipal Hospital, Whitefield, Bangalore. And ma'am has received Dr. C.S. Dawn Award for Best Representation at AIC 2012, Times of India Award for Rising Category, Star Category in Obstetrics and Gynecology, and presented many papers in state and national and international conferences. We welcome you, ma'am.
Thank you.
Over to chairpersons.
Dr. Sushila is not joined. Shweta, are you sure?
Ma'am,
I think. So, Tasneem madam, thank you so much for accepting our invite. And
Thank you.
please do the honors by introducing our speaker.
Yeah, it's a pleasure to be a part of Synergy 16 program, especially with all the dignitaries here. thank you, the organizers, for giving me this opportunity to be a chair the session. Ma'am, can I have ma'am's CV?
The CV is displayed,
Yeah,
madam.
sure, fine. Yeah. Divya ma'am is a gold medalist from IGMC Shimla and a bronze medalist from PGI Chandigarh for MD radio diagnosis, fellow advanced OB-GYN ultrasound from Mediscan Chennai, and short-term training in medical genetics, ICMR Mumbai. At present, Madam is a consultant radiologist in Mirchia's Diagnostic Center, Chandigarh, and chair ISUOG CMA subcommittee, member of ISUOG Outreach and Educational Committee. Madam has been awarded by the Ministry of Health, Government of India by providing exemplary service to pregnant women in Chandigarh and best oral paper on ultrasound in endometriosis in Sonocon 2020. Ma'am has published 57 papers and 2 chapters in textbooks. I welcome you, ma'am, for your session.
Thank you, Tasneem ma'am, for the kind introduction, and good evening, everyone. Thank you, Dr. Monica and Team Synergy for having invited me again to this academic feast. It's always a pleasure and a privilege to be here, and I'm grateful to Sita ma'am for having provided me a solid foundation for my talk by introducing the concept of twins so eloquently. So my task today is to speak on how to unravel congenital anomalies in twins. And we all understand that since the incidence of twinning is on the rise owing to advanced maternal age and use of ART, we encounter twins with congenital anomalies more often. Twins have a higher incidence of congenital anomalies than singletons. This is true more for monochorionic twins, that is, twins who have a single placenta as compared to dichorionic twins. And in monochorionic twins also, it is the monoamniotic monochorionic twins who are much more predisposed to congenital anomalies as compared to diamniotic twins. The common malformations which various studies have seen especially in like-sex twins include malformations involving the central nervous system, the cardiovascular system, and the genitourinary system. Now, whenever we come across congenital anomalies in a twin pregnancy, there are various issues that we need to address. And the first issue, of course, as has been highlighted repeatedly by ma'am, is chorionicity. None of our reports today should ever say that there is a twin pregnancy. We must always make an effort to establish the chorionicity of our twin pregnancy, because that is what determines how we manage the pregnancy. And if, God forbid, there is a congenital anomaly, then how we go about managing and counseling regarding the same depends or is determined a lot by chorionicity. There's increased risk of certain abnormalities like those of CNS, cardiovascular system, and limbs in twins because of problems in the splitting of that fertilized ovum. So when that split occurs, there can be anomalies more towards the end of the embryonic discs or in the midline, and that is why these kind of anomalies, that is those involving either the central axis of the embryo or involving the periphery like the limbs, tend to be more common in twins. Certain abnormalities which occur in twins occur because of ischemia, and they can affect organs like the brain, gastrointestinal tract, and the kidneys. Also, because of these anomalies, there can be varied impact on the pregnancy. There can be demise of a twin, or because of an anomaly, there can be a marked increase in amniotic fluid, which again predisposes to prematurity. And of course, there can be fetal hydrops due to various causes. Now, how do we, supposing there is an abnormality which we have determined that it's likely to be a lethal abnormality, then selective feticide is an option which is offered based on the chorionicity of pregnancy. Typically in dichorionic pregnancies, it's recommended to go for selective feticide early, that is before 15 or 16 weeks, because at that point of time, the miscarriage rate is lower, which is to the tune of 5%, and after that it increases. Whereas in monochorionic pregnancies, if selective feticide is to be opted for, it is usually recommended to go for that between a gestational age of 18 to 24 weeks, because before 18, there is again increased risk of miscarriage if we intervene. And after 24 weeks, in various advanced NICUs, it's believed that they can save the babies. And so unnecessary feticide, which can precipitate preterm labor, is discouraged. Also, as ma'am discussed, the option of feticide in dichorionic pregnancies and monochorionic is different, because dichorionic twins have got separate placenta without any vascular anastomosis, and therefore intracardiac instillation of potassium chloride or lignocaine is a suitable option because there are no anastomosis. So what we give one twin is not likely to affect the other. On the other hand, in monochorionic twins, since there's a single shared placenta, so there are extensive vascular anastomosis between the two circulations of the babies, and so we cannot give intracardiac instillation of either Potchlor or lignocaine. And what we do in monochorionic, if we have to go for selective feticide, is to occlude the cord of the twin which we have selected for reduction, either by using bipolar cautery or radiofrequency ablation or laser. Rarely, not in our setting, but in certain settings, one does consider the option of fetal therapy. But again, in twins, considering option of fetal therapy involves considering a lot of risks and benefits, and usually the risks outweigh the benefits and is not resorted to. And as ma'am discussed, based on the anomalies, we may or may not decide to change the timing as well as mode of delivery. Now, before I start talking about anomalies, I would do a brief recap of chorionicity. Easy way to remember is that if two individuals stay together for a long period of time, they tend to share a lot of memories and stuff together. So if a zygote divides early on, say between day 1 to 3 post-fertilization, the twins are totally separate. They have that separate placenta, separate sacs. So we have dichorionic, diamniotic twins. However, if this cleavage occurs between day 4 or day 8, then we have monochorionic twins, that is with a single placenta, but they still have their separate compartments, that is they are diamniotic. And then if the cleavage occurs, say between day 8 or 13, then they tend to have a single chorion, single amnion, monochorionic, monoamniotic twins. And if the cleavage occurs even later, so that is the ovum remains or the twins initially remain together for a long period of time, then what we get is conjoined twins. So later the division of the zygote, more closely the connections between the two fetuses are going to be. Also, we must understand that zygosity and chorionicity are not synonymous terms. Now, zygosity determines the number of zygotes which led to the formation of a twin. So monozygotic twins would arise from a single zygote, whereas dizygotic twins would arise from two different zygotes. On the other hand, monozygotic twins can be dichorionic. So they can, depending on when the fertilized ovum split, if it's split early, they can be dichorionic diamniotic. And if it's split later on, then they can be monochorionic di or monoamniotic. In monochorionic twins, the most common chorionicity is monochorionic diamniotic, followed by dichorionic diamniotic, and then monochorionic monoamniotic. So basically, zygosity and chorionicity are not synonymous. Now, I've been highlighting about the typical placental angioarchitecture of monochorionic twins, and this is an illustration to explain the same. So in a monochorionic placenta, as I said earlier, if these are the umbilical cords which are forming vascular anastomosis on the placental surface, there are two types of anastomosis. The unidirectional arteriovenous anastomosis. So since they are unidirectional, the blood will flow in only one direction, that is from artery to vein. And it is these unidirectional arteriovenous anastomosis which are responsible for the occurrence of twin-to-twin transfusion syndrome, because there occurs fluid shift from one twin, that is the donor twin, to the recipient twin. And so the donor twin becomes hypovolemic, whereas the recipient twin becomes hypervolemic and polyuric, and that is what gives rise to the oligopoly sequence. So the donor twin, because it's losing fluid, its renin-angiotensin aldosterone system gets activated, and its kidneys the vascular supply to the kidneys reduces, and that is why urine output decreases. So it becomes oligouric and has oligohydramnios, whereas the recipient twin, which gets a lot of fluid because of these AV anastomosis, its biochemical mechanisms result in polyuria, resulting in polyhydramnios. On the other hand, there are also presence of these bidirectional arterio-arterial anastomosis. And these bidirectional anastomosis, since the blood can flow in either direction, tend to protect from TTTS. So the placenta, which have a lot of these bidirectional arterial anastomosis, are less predisposed to twin-to-twin transfusion syndrome. But everything comes with pros and cons. And these large bidirectional arterioanastomosis, because they are bidirectional, they will allow flow of blood in either direction. They become a problem when there is a twin demise. So if there is a twin demise, now since these anastomosis arterioarterial are bidirectional, then they will result in the flow of blood from the live twin into the dead twin and cause exsanguination of the live twin into the dead twin. And that is why the live twin, because it loses blood into the dead twin, has a lot of problems because of hypoperfusion, hypoxia, ischemia. And this is how we can show the presence of these bidirectional arterioarterial anastomosis. If we try to look for these anastomosis on the placental surface near the cord insertion sites and put pulse wave Doppler, because they are bidirectional, they show this to and fro flow of blood. And if we can see these anastomosis on the placental surface, it is suggestive of presence of these arterioarterial bidirectional anastomosis, which are protective from TTTS, but become a problem should there be a one twin demise. Now, as I said monozygotic twins come from a single zygote. So we automatically presume that they are going to be genetically identical. But I'm afraid genetics is not that simple, and that is not the case. In fact, if you go deep into genetics of monozygotic twins, they are rarely truly genetically identical. This is because even when the ovum is getting split, there can be difference or missegregation in the genetic and cytoplasmic material between the two embryos that are going to form, and this can result in two different type of cell populations. So there can be two different cell populations within the same twin. Then even the mitotic process, the cell proliferation that occurs post formation of the two embryos, can have certain errors which can result in difference in the genetic makeup of the monozygotic twins. Then there can be differences in imprinting. By imprinting, what we mean is that there are all of us, we understand, get 2 copies of every gene, one from mom, one from dad. But there are certain genes which are not expressed, both the copies are not expressed, and only one copy either from the mother or from the father is expressed. And sometimes, supposing normally the copy from mother was supposed to be expressed, but instead a copy from the father gets expressed and the maternal copy doesn't get expressed, then it results in a totally different phenotype or external appearance and can be a cause of a disorder. So just simple difference in the expression of genes can result in totally different phenotype even in monozygotic twins. Then there can be difference in telomere size. Now, telomeres are certain repetitive sequences which are present at the ends of chromosomes. They prevent the chromosomes from sticking together during cell division. Now, what happens during successive cell division? These telomeres decrease in size, and that is what results in cell aging and cell death. So there can be difference in the size of telomeres in the cell population of even the monozygotic twins, and that is why the expression of cells or genes can be different. And also the inactivation of X chromosome that can occur as a random process in one of the two embryos, resulting in a different phenotype. So thinking that monozygotic twins have an identical genetic makeup is something that we have to do away with. Concordance of anomalies. This means the presence of occurrence of anomalies simultaneously in a twin pregnancy. Now, this has been found to be to the tune of 20%. Malformations in dizygotic twins, that is twins which have come from two different zygotes, occur at the same rate as singletons. So dizygotic twins are not more predisposed to malformations as compared to singletons. On the other hand, monozygotic twins tend to have a higher incidence of malformations. Why? Because of the problem in the twinning process, that is in the way the splitting occurs, or because of the effect of the hemodynamic complications which are referred to because of the shared placenta. Now, generally for most chromosomal problems, dizygotic twins, because we know they arise from different zygotes, generally they are discordant, so that if one fetus has a chromosomal anomaly, the other fetus is less likely or unlikely to have the same anomaly. On the other hand, monozygotic twins, they are almost identical usually, but not 100%. So monozygotic twins, if we see a chromosomal issue in one fetus, it's highly likely that the other fetus may have the same chromosomal issue as well. Now, coming to structural malformations unique to twins. Now, any malformation can occur in twin pregnancy, but there are certain malformations which are unique to twins, and this is because of the peculiarity of this twinning process or the duplication process. And as I said earlier, monochorionic twins are more predisposed than dichorionic twins. Monozygotic are more predisposed than dizygotic twins. So certain anomalies which are peculiar to monozygotic duplication involve duplication abnormalities which are symmetrical, and these are known as the conjoined twins. There can be asymmetrical duplication abnormality where one fetus is more or less normal while the other fetus is malformed. And we will discuss these shortly. So first I come to the symmetrical duplication abnormality, which I said are the conjoined twins, which occur when there is late cleavage of the fertilized ovum. And as a result, there is not only sharing of vascular anastomosis, but physical sharing of parts between the two embryos. And this was one monochorionic monoamniotic twin pregnancy, which we saw at 8 weeks, where the two fetal poles on grayscale appeared very close to each other. The two fetal poles seemed to be very close to each other, and there seemed to be a single cardiac activity. And this 3D rendered image can show you the presence of these two cranial poles. So these are the two cranial poles of the fetus identified by the presence of the diencephalon. But when we come below the level of the head, there is distinct fusion of the two embryos starting at the level of the neck and even involving the abdomen. This is just the single yolk sac, not a part of the embryonic poles. And this is just to show you that conjoined twins is something which we can diagnose even as early as before 10 weeks if we look closely at the fetal poles. And these are the various types of conjoined twins which have been described in literature. So if we have a look at our twins, there appeared to be lateral fusion, and these were parapagous dicephalous. So we could see two separate heads, but there seemed to be fusion of these embryos below the level of the heads, as you see in this illustration. Now, conjoined twins tend to have a very high incidence of anomalies to the tune of 80%. And most significant are the cardiovascular anomalies, because these make the separation of these twins particularly challenging and affect long-term survival. The intrauterine mortality rate in conjoined twins is as high as nearly 50%. Now, we spoke about symmetrical splitting abnormalities in monozygotic twins. Now I'm coming to asymmetrical splitting, whereas I said one fetus would be more or less normal appearing, while the other fetus would have some abnormality. And ma'am has already alluded to this, so I would just make a brief mention of the twin reversed arterial perfusion or the TRAP sequence, which is quite rare. It is unique to monochorionic pregnancy, so it doesn't occur in dichorionic, it occurs in monochorionic pregnancies and has an incidence of 1 in 35,000. Now, as ma'am said, usually one twin is structurally normal, and that is called the pump twin, because that twin is going to pump blood into another acardiac acephalic mass. So a twin mass in which the upper part of the body is not developed, and we usually don't see cardiac activity, but it has an umbilical cord, and through the umbilical cord it is receiving blood from the normal pump twin. Now, since one twin is pumping blood into the other, this normal pump twin is at the risk of hyperdynamic circulation and high output cardiac failure. So when we monitor these pregnancies with TRAP sequence, we look for evidence or changes of cardiac strain in the normal pump twin. There can be polyhydramnios in the pump twin. And of course, we look for the volume or the growth of the TRAP mass. So this is just an illustration to show you this pump twin and the blood flowing from the pump twin into the TRAP mass, which doesn't have a heart and doesn't have a cranial half of the body. And a video clip of a monochorionic diamniotic pregnancy where this was the totally normal pump twin. And adjacent to the pump twin, there was presence of this amorphous mass, which had a cord insertion, but its upper part of the body or cardiac activity was not seen. And as I told you, this is the cord insertion site. So when we switched on color Doppler, we could actually see the blood flowing through this cord insertion into the into the trap mass from the pump twin. Now, there's another thing which is known as parasitic twinning. Again, in this, there is asymmetry between the twins, but as the name suggests, one twin lives either inside or on the host twin, which is called as the autosite. So in trap mass, there were two separate masses with different cord insertions, but in parasitic twins, the one twin would be in physical contact with the other twin, which would be a normal host twin or the autosite. So that one parasitic twin can either develop on the surface of the body when it is called as an ectoparasite, or it can develop within the body of the normal twin when it is called as an endoparasite. This is an example. I have not seen any antenatal case of ectoparasitic twin, but this is a case from literature showing an ectoparasite twin at birth when this abnormal mass having 1 foot and a poorly developed scrotum was seen attached to a normal baby, and this was the ectoparasitic mass which was subsequently separated surgically. So you can see that there is physical contact between the parasitic twin, which is on the surface of the host twin. On the other hand, the endoparasitic twin, when one twin develops within the host or the autosite, is what we also call as fetus in fetu. And this is another case from literature in which in the third trimester, initially the mid-trimester anomaly scan was normal, but in the third trimester, this solid cystic mass was observed in the fetal abdomen. This is the fetal urinary bladder, and in the mid and upper abdomen, this mass was observed. And when one observed carefully, one could actually see bone within the solid component of the mass, and this was actually a lower limb, and hence an endoparasitic twin developing inside the host twin. Another case, this is postnatal, in which a mass was seen in the neonatal liver, and when high resolution ultrasound was used, one could actually see presence of vertebral bodies in this mass. So this was again a case of fetus in fetu developing in the liver of the host twin or the autosite. And just a CT image to show you those vertebral bodies of this endoparasitic twin. Now we've discussed problems in the splitting process, symmetrical and asymmetric in monozygotic. Now we move to the problems in monochorionic twins, and Dr. Sita has already alluded to them. So this is going to be a quick revision. As I said, in monochorionic twins, because of these arteriovenous anastomosis, there can be imbalance in the net flow of blood from the donor twin to the recipient twin, and this can result in the TTTS, starting with the oligopoly sequence and going on to have discordant bladders, discordant Dopplers, hydrops, and eventually fetal demise. The incidence of TTTS in twin-to-twin in monochorionic pregnancies is to the tune of 10 to 30%. And I've already described the pathophysiology. But what is interesting in monochorionic, in the presence of TTTS is that monochorionic twins, they are predisposed to congenital heart diseases like VSDs and ASDs. But right ventricular outflow tract obstruction, particularly pulmonary stenosis, tends to be more common in monochorionic twin pregnancies complicated by twin-to-twin transfusion syndrome. So it has been found that in recipients, that is the baby who is getting more fluid and having polyhydramnios, the recipients who are particularly in higher stages, that is stage 3 or 4, with abnormal Doppler or with hydrops, they can develop acquired right ventricular outflow tract obstruction. So pre-TTTS, their hearts might have been perfectly normal, but as a consequence of TTTS, they can develop right ventricular outflow tract obstruction, which can manifest in the form of pulmonary stenosis in the majority of cases and can be even more severe and lead to pulmonary atresia. And this was one such case of a twin with stage 3 TTTS in which the recipient twin was having pulmonary atresia. I say it is pulmonary atresia because there was reversed flow in the ductus arteriosus, and this was the reversed flow through the pulmonary valve. So there was no forward flow across the pulmonary valve. Normally, this is the aortic arch flow. This is the ductal arch. There should have been blue, that is similar flow in both the aortic and the ductal arches, but because of pulmonary atresia, there was this reversed flow, and we could see this pick up the regurgitant reversed jet on pulse Doppler as well. So this is important to know, and that is why it's important to do fetal echocardiography again if there is development of TTTS in monochorionic pregnancies, because a lot of cardiac issues can crop up because of twin-to-twin transfusion syndrome. Another thing which can happen in the recipient, because of increased fluid which is going to the recipient twin, there can be increased pressure on the right hand side, because all the fluid will go to the right hand side via the ductus venosus, and this increased pressure or fluid in the right heart can give rise to problems in the tricuspid valve and tricuspid regurgitation, as we can see here. This is the regurgitant tricuspid jet, and this is important to know because actually, this baby had tricuspid regurgitation consequent to twin transfusion. There was just discordance in the amniotic fluid in the two sacs and presence of this cardiac finding. The Doppler findings were not there, but still this would be labeled as twin-to-twin transfusion syndrome, and that too stage 3 because there is cardiac decompensation. However, this case had been seen by a cardiologist, and since cardiologists are not aware of this monochorionic twin specific complications, initially a call of Epstein's anomaly had been made in this case when this was just a case of TTTS. So it's very important to know that especially in monochorionic pregnancies, if there are valvular regurgitations, especially in the right side, or if there are valvular problems in the right heart, they are not always due to structural issues, but can be due to functional or hemodynamic issues as well. Now, ma'am has highlighted the significance or the consequence of co-twin demise in monochorionic twins. And this was one such case which we saw of a monochorionic diamniotic pregnancy in which there was selective fetal growth restriction, and as a consequence, one twin passed away. When we saw the pregnancy, it was at 21 weeks, and we do not know the pregnancy was seen in the first trimester, and after that it wasn't, the patient did not comply with follow-up. So obviously the brain had to be seen in detail. Why these problems occur, as I had highlighted earlier, when there is death of one twin, there is exsanguination or loss of blood from the live twin into the dead twin, and as a result, there would be hypovolemia because you are bleeding into the dead twin, and this hypovolemia results in hypoxia and ischemia, and the most vulnerable organs in a person's body are the brain, kidneys, the GIT, which do not have a collateral supply, and these are the organs which get targeted. Since manifestations of the brain have the severest repercussions in terms of neurodevelopmental outcome, they have been described extensively and they are sought for actively. So whenever there is a co-twin demise, it's recommended to do an MRI 4 to 6 weeks after that, because these abnormalities take some time to come up or appear. And in this case, if we notice, what we could see here was that this is the lateral ventricle of the brain. Normally, we should have seen some amount of occipital brain parenchyma behind this lateral ventricle, like this hypoechoic brain parenchyma, but nothing was seen. Instead, just this echogenic tissue was seen, and this was secondary to gliosis, which had occurred because of brain ischemia. So this baby had got occipital periventricular leukomalacia because of co-twin demise. Also, since there is exsanguination, we could also see a cardiomegaly because the heart was dilated because the baby is losing blood, and so the heart is also getting less blood flow, and that is why it gets dilated, as you see in this case. Now, there can be problems in twins because of interference in the normal developmental process as a consequence of hemodynamic abnormalities secondary to vascular anastomosis. And you've just seen one such example in the previous case, where because of one co-twin demise, there is hypoxia, ischemia to the brain. This can result in conditions like microcephaly, porencephaly, hydranencephaly, and if there is ischemia involving the gastrointestinal system, it can result in bowel atresias. So bowel atresias can be because of vascular problems, and ischemia to the skin can result in a condition known as aplasia cutis. So this is the importance of understanding chorionicity and the repercussions of co-twin demise. Now coming to discussion about aneuploidy in twins. Now there is this interesting paper published long ago which has shown that actually the risk of Down syndrome per fetus is lower in multiple than in singleton pregnancy. So we are always worried about trisomy 21 and we are screening for it all the time, whether we see a pregnancy in the first or the second trimester. Now, this paper describes that the risk of Down syndrome is lower in twin pregnancies as compared to singletons. Now, typically when we counsel a lady who is 35 years of age at 12 weeks of gestation, that is during the NT scan, we say that the risk of having a twin baby with Down syndrome is 1 in 200. But actually, in monochorionic twins or in dichorionic twins, the risk that only one fetus would be affected with trisomy 21 is 1 in 200 or even lower than that. Whereas in dichorionic twins, the chance that both the fetuses can have trisomy 21 is very, very low. So the risk of having Down syndrome or aneuploidy is not increased in twins, and we should not worry from an aneuploidy standpoint in twins pregnancy. Now, there can be a lot of structural abnormalities, but today in the era of inversion of pyramid of prenatal care, we start screening the twin pregnancies in the first trimester and look for certain red flags on ultrasound on the basis of which we suspect that these twin pregnancies can have an adverse outcome or are predisposed to certain anomalies. For instance, if there is a difference in CRL of more than 15% in the first trimester, that is a red flag. A difference in nuchal translucency of 20% or more is another red flag. Similarly, if we have discordance in the ductus venosus or the tricuspid wave form, and of course, if there is discordance in the anatomy, then it's a sonographic red flag anyway. Now, this is a case of a discordant monochorionic pregnancy, if I say with discordant NT. Now, whenever we see discordance of NT, we understand that we are worried about aneuploidy, we are worried about structural cardiac defects. But in the context of monochorionic twins, this discordance in the nuchal translucency is a predictor for development of twin-to-twin transfusion in the second trimester. And in fact, in monochorionic twins, rather than these aneuploidy and structural defects, we also counsel about the possible occurrence of twin-to-twin transfusion syndrome at 16 weeks. And of course, if there is a lot of discordance in NT, then the twin with the larger NT has the risk of having a demise. Now, talking about congenital anomalies and assisted reproductive techniques, now studies have seen that use of ART increases the relative risk of congenital anomalies to a certain extent. It doesn't double, but a relative risk of 1.4 in singletons and 1.3 in multiple pregnancies. And there are certain congenital defects which have been found to be more common in ART pregnancies, particularly those pertaining to the cardiovascular, genitourinary, and the muscular skeletal system. The most common defects that we see are those of the genital system, like hypospadias, omphalocele, and neural tube defects. Now, with this, I come to the end of my presentation. And again, I stress the importance of establishing the chorionicity in pregnancy and then addressing any twin pregnancy, be it normal or a twin pregnancy with a congenital anomaly. Of course, the moment you say that the pregnancy is monochorionic twins, then there is double the incidence of anomalies. And that is why monochorionic twins, when we do their mid-trimester scan, we also recommend doing a fetal echo in all monochorionic twin pregnancies because of higher incidence of anomalies. Particularly, we must be careful about presence of cardiovascular, CNS, limb, and renal anomalies in monochorionic pregnancies because of problems with the vascular anastomosis. Please remember that all echocardiographic findings, especially right-sided valvular lesions, are not due to structural defects, and they might be just a marker for twin-to-twin transfusion in monochorionic pregnancies. Also, the risk of aneuploidy is lower in twins than singletons. So just because somebody has twins, do not think that they are more predisposed to having aneuploidy, and start looking for the red flags for congenital anomalies right during the first trimester NT scan. Thank you.
Thank you so much, Dr. Divya, for the beautiful talk. And it was very illustrative with your typical flow charts and diagrams, which are hallmark of Dr. Divya's talk, very brightly put out on a black background. I
Thank
think
you.
black is your favorite color for the slides.
And
So
radiology images come out better on a black
very,
ground.
very striking. So there's a question in the chat box, Dr. Divya, who in India is doing RF occlusion in later cases of pregnancy? Dr. Jayashree Sridhar has asked this. Dr. Jayashree, you can unmute and ask directly if you want to ask that query from the speaker. Dr. Jayashree?
Many of the prominent fetal medicine centers who are doing therapies are offering the option of selective reduction. But as I told you, after 24 weeks, especially in monochorionic pregnancies, people are not that proactive in doing a reduction because they are also worried about the risk of prematurity and losing the entire pregnancy. So there's a lot of counseling which is involved in doing a late reduction if you're talking about monochorionic because
Yeah,
you're
monochorionic, yeah.
yes, because you're talking about radio frequencies,
yeah,
you're talking about monochorionic. So as I said, 18 to 24 is the golden
Yeah,
window for
vaso-occlusive.
doing
Who's
reduction.
doing the vaso-occlusive?
Ma'am, it's done in most therapeutic fetal medicine centers. If I may quote Mediscan Chennai, BFMC in Bangalore, North Apollo. So
Okay.
these are ones
Thank
whom
you.
Yes,
Yeah.
yes.
And anybody doing corrective surgeries for diaphragmatic hernia,
Not yet
meningomyelitis?
that I'm aware of, ma'am. Not in
Okay,
India.
thank you.
Not in
Thank you.
India. Yes,
Not
ma'am.
yet in India, yes.
So I just missed that part, Divya, when you were talking about fetus and fetu.
Yes, ma'am.
So how come that fetus gets there in the other fetus's liver? Like, what is that root or what is it?
Ma'am, actually, the division is such that the two zygotes, they don't physically split with each other.
Yeah.
So one embryo that develops within the other embryo. It's not like a proper developed embryo. It's
So
just
this is that social
mass of
media
tissue.
thing which, people talk
Yes.
about, and it's
Yes.
there on YouTube and all, that fetus inside a fetus and all
Yes.
those
Yeah,
things which are
fetus
talked
in
about
fetu.
is
Yes.
actually a biological thing.
Yes.
I think Dr. Divya has gone out of network.
Ma'am, I can hear you. Can you hear me, ma'am?
Yeah, we can hear Divya. But we're
Yes.
not, I think we've lost Monica.
I think we can't hear ma'am.
We can't see her either.
Yes, she's frozen.
So the MC can take over? Mhm.
And Dr. Divya, it was a very informative talk. I hope
you,
we
ma'am.
all our knowledge has increased a lot by hearing your talk.
Thank you, ma'am. It's a pleasure. Thank you.
Hello. Monica is
Good
there.
Yes. Good evening, Sumitra ma'am. Welcome to Synergy. Dr. Sumitra is there, Purva?
Yes, ma'am, she's
Okay, good evening, Sumitra ma'am. We welcome amongst our August gathering a great teacher and academician, President of Indore Obs Gynae Society, Professor Dr. Sumitra Yadav, who is who is Professor OBGY at Mahatma Gandhi Medical College and MTH Hospital, Indore. Madam holds a vast teaching experience of more than 3 decades. She has been up at the forefront of major national conferences, ISAR, AICOG, MPOX, and has held various executive posts in IOGS, which is one of the most vibrant FOXY organizations of the state of Madhya Pradesh. Very active in the health department, in the Ministry of Health and Family Welfare, NACO expert, been awarded HIV Utkrisht Seva Award, Nari Shakti Award, Nai Dunya Naika Award, Nai Dunya Award for Utkrisht Chikitsa Sahyog, winner of Dr. C.S. Down Award twice, Young Scientist Award, and State Award of Karnataka as a national topper in 10th and 12th. Madam is from a defense background, so Madam and I, we always gel together because of our roots. She has been, very active in social front also, Mahila Utpidan Samiti of MGM Medical College, Violence Against Women, Harassment at Workplace and POXO, expert member in PCPNDT of the State, District MTP Board, ART Regulation, District Committee. We welcome you, ma'am. And we would be honored to have a few words from you, madam.
That's very nice of you, Dr. Monica. I was listening very quietly to what is going on because I was busy in an emergency and I couldn't join at 5. But what I find that the person, I couldn't get the name, but was speaking too nicely about the discordant and the co-twins. And it was very significant question, which every, I should say, budding obstetrician should learn. And what I would like to compliment you is that you've chosen very nice subjects always in your series of Synergy, and you are educating people regarding the simple one-to-one activities. It is a real honor for me to be present here, and I was listening very quietly. I didn't wish to be, introduced. It's okay because I'm also learning. I'm really happy. Very good. All the best to you for your future endeavor as a committee chair. I am looking forward to seeing you as a committee chair. All the very best. Bye.
Thank you so much, Sumitra ma'am, and your blessings. In fact, it is very difficult to get hold of you because you're always on the go, you know. Morning, you're rushing to college, then you have meetings, evening, you are rushing to so many other commitments. So we are very honored. And as soon as you joined, my colleagues, they inform me, madam has joined. So we make it a point that whoever takes time, madam, you are a family of Synergy, and we have to honor you, and we are blessed to have you amongst us. So now the most awaited panel is here, and I heartily thanks Charmila ma'am for bearing with us and always being there. Madam,
Sharmila
it's
is
so
wonderful, charming.
Ma'am, it's so great to have you as a moderator finally, because I've heard your panels and there is absolutely no topic under the sun that Madam cannot have mastery on and cannot moderate in a dynamic way, which only Charmila ma'am can do. Welcome, Madam.
Thank you, Monica. Thank you. Can you introduce the panelists, please?
Yes, ma'am.
Yeah.
Now moving towards our much awaited panel discussion, that is on antenatal and infranatal management of twin gestation. To moderate the panel, we have none other than Dr. Chamila Yoabu ma'am. Madam is presently ICOG Governing Council member. She was past President Foxy. She is Vice President of Trichy.
Vice
And
President Fox.
yes, ma'am, Vice President Foxy. Yes, ma'am. And Chairperson, Clinical Research Committee. She's a very fond academician and a convener of various programs like Medha Foxy PG program, ISAR Gurukul program, series convener for ICOG Journal Club and ICOG certificate courses. She's also an active Indian member of WHO Southeast Asia region. She was President Menstrual Hygiene Management Consortium. Also, she was Secretary Justice India Association and Academic Wing of Assisted Reproduction. Also, Managing Committee member of PCOS Society of India. We welcome you, ma'am.
Thank you so much, Pro. Thank you. Please introduce the panelists so that we
Yes,
can
ma'am.
start.
Now we move on to our dynamic panelists. We have Dr. Bharti Parihar, madam. Madam is presently professor in unit head in Department of OBGY at GMC Bhopal. She is also joint secretary of Bhopal Obsgynae Society. We welcome you, ma'am. Next, we have Dr. Jayashree Sridhar, madam. Madam is presently director and consultant at Vishesh Jupiter Hospital, Indore. We welcome you, ma'am. Next, Dr. Kavita Babar, ma'am, could not join due to prior commitments. Next, we have Dr. Komal Jain, ma'am. She was also involved in other program and commitments, so she is not able to join. Next, we have Dr. Nidhi Bajaj, ma'am. Madam is also presently not here. Next, we have Dr. Ranu Dadu, ma'am. Madam is a very senior IVF consultant at Baby Joy IVF and also at Fortis Hospital. We welcome you, ma'am. Next, we have Dr. Richa Hiravani, madam. Madam is director and consultant at Jabalpur Hospital and Research Center, Jabalpur. We welcome you, ma'am. Next, we have Dr. Sangeeta Maheshwari, madam. Madam is center head at Genesis IVF, Dehradun. We welcome you, ma'am. Next, we have Dr. Shashmita, ma'am, was not able to join. Next, we have Dr. Sanujit Kaur, madam. Madam is presently associate director at Department of Fertility and OBGY at Cloud9 Hospital, Chandigarh. We welcome you, ma'am. Next, we have Dr. Srishti Gupta, madam. Madam is a very senior consultant at Agarwal Nursing Home, Delhi, and also various visiting consultant at various hospitals in Delhi. Dr. Sonal Rizaria, ma'am. Madam is not able to join the webinar due to prior commitments. Now I hand over the session to our moderator, madam, Dr. Charmila.
Thank you, Purva. Thank you so much for that. I'll just share my screen.
I request all panelists to please switch on their videos so that madam can see you all.
One second. Can you see my slides?
Yes, ma'am. Yes, ma'am. Yes, ma'am. We are able to see this.
No, I made it this thing. So I'm entirely indebted to Monica for giving such a great group of panelists. All the people are very, very academically oriented as well as very much into the field. And it's an honor to have Jayashree Sridhar. It's a good friend of mine since COVID, I would say, because we have interacted almost over through webinars. And Dr. Bharati, Dr. Jayashree, Dr. Ranu, Dr. Richa, Dr. Sangeeta, Dr. Shanujit, and Dr. Srishti are there. And others are not able to join today. I hope I've got all the names right. Is it fine?
Yes.
Yeah.
Yes, it's okay, ma'am.
So we have already had such great talks, 2 talks on multiple pregnancy, both so extensive. So that I think we should keep the panel to just clinical opinion of how we manage multiple pregnancies. So I request that short opinions are given, and we don't want speeches and talks because we want everybody to give their inputs. And we request that other opinions are also heard. But I would always urge you to have controversial opinions so that we have an interesting panel, so that I don't want everybody to agree with the other person. I request you to disagree so that you have a more interesting panel. But always remember that the moderator is always right. And you're not supposed to ask me any questions, right? Okay. So the first patient, she is a 33-year-old primey. She's had a menstrual history of only withdrawal bleeding, and then she was diagnosed to have a premature ovarian failure. Married since 5 years. We did an egg donation and an IVF cycle, and she conceived with diamniotic dichorionic live twins. That's what the diagnosis is. But Dr. Bharati, like when a fetal medicine specialist tells us that you've got a twin pregnancy, what is our point of view? Because they were talking about the fetal part, but the maternal part. So the fetal visit, the first visit, what is important for us?
Good evening, everybody. Am I audible?
Yes, Dr. Bharati, you're audible. Yeah.
So the first trimester diagnosis of twin is very important.
Yes.
There are few points which not to be missed in diagnosis of twin pregnancy. So first is vaginal, the transvaginal ultrasound. It is important for diagnosis of twin pregnancy. It can detect the pregnancy as early as at 6 weeks.
Yes,
so first very important point in first trimester ultrasound is determination of chorionicity. It should be established as early as possible in twin pregnancy because it plays very important role in determining obstetric risk and management.
Yes.
So determination of chorionicity is very important.
And
First,
how do
very
you,
important.
how as an obstetrician, suppose we don't have a fetal medicine specialist, we do the scan. How do you identify the chorionicity? And very, very brief, because we heard talks on that.
So we can see for either lambda sign that is very specific of dichorionic. Usually we do chorionicity determination by anti-scan and should be determined between 11 to 14 weeks of gestation when the amnion and chorion have not yet fused.
Okay.
So because accuracy is very high in first trimester. So we can determine chorionicity by number of placental masses, by presence of amnion between the two sexes, and by seeing this lambda sign or T sign. Lambda sign is specific of this dichorionic diamniotic pregnancy, which is the triangular appearance of the chorion between the layers of intervening membrane. And you may see the T sign, which is specific of monochorionic diamniotic pregnancy, where the twins are separated only by 2 thin membranes.
Yes.
So these are the important signs by which we can determine the chorionicity.
Thank you so much. Dr. Jayashree,
Yeah.
every multiple pregnancy, would you advise a selective reduction? I heard your question on that. But
no, in my experience of doing IVF, like, you can carry your twin pregnancy to term unless if there's a if she's got a uterine anomaly, unicornuate uterus or something. Otherwise, twin pregnancy, I really don't recommend reduction. And nowadays, we don't do a triple embryo transfer much, So
Okay.
triplets have, unless there is a de novo, IVF resulting in triplets have reduced drastically over the last 5-6 years.
Yeah. And monochorionic twins, is it advisable to go for a reduction?
No, it is contraindicated
Indicated.
because then you lose the pregnancy.
Yeah. So that we have to be very
Yeah.
clear. That's why Dr. Bharati's answer of determining the chorionicity is very important. And
Yeah.
many times, even if you have triplets, you have to wait till at least 9 to 11 weeks because sometimes spontaneous reductions are known to happen. So you do not rush to counsel the
So we
patient.
wait for the
Wait,
NT scan, yeah.
wait for the NT scan. And as Jayashree said, nowadays we do a single embryo transfer in most of our IVF procedures. So we don't have the multiple order pregnancy, but it is very common in IUI pregnancies because there we don't have a control over the follicular number.
Yeah.
So that's why you have to be very careful, and always remember heterotopic pregnancy is also quite common when you do an IVF or an IUI. And that's why when you do a scan for a confirmation of the viability and chorionicity, check for the embryo on the
Adnexa.
also, because nowadays we're seeing lots of cases with heterotopic pregnancy. And do we need to monitor if you've done a reduction for a triplet pregnancy, the mother's monitoring? Because many are worried about the coagulation profile, infection setting in the mother. Do you do any monitoring for any of that when you do a selective reduction?
For diamniotic, no, I don't do any
Don't do.
monitoring.
Because there's no coagulopathy which happens just because you reduce
No,
one
no,
to
no,
so
no.
don't worry about it at all.
For such early.
Yeah. And Dr. Kavita is not there, so can you take this question, Jayashree, like maternal
Yeah.
surveillance protocol? Like it's a diamniotic dichorionic twin, so you have to counsel the parents of what all they're supposed to expect. So what will be the maternal surveillance protocol you will put in place when the diagnosis is made?
Pre-op, we have all pre-delivery, we have already assume that we have done the routine thyroid and sugar and screening, but we need to tell her that she'll be at a higher risk for preterm labor, around 5 to 10% increased risk of preterm labor, and also increase of risk of PIH and gestational diabetes. So I'll have to ask her to, check, ask her to keep a check on her weight. We don't want a very excessive weight gain. So 40 minutes of walk, I advise all of them, because we don't want them to, they want to do rest, as soon as you tell them it's a twin pregnancy, they'll stick to the bed, So we have to insist that you do a 40-minute walk in every visit. That is supposed to decrease the incidence of preeclampsia by over 25%. So I ram it into their head, 40 minutes walk, बहुत important.
And as you said, it's very important that you counsel the parents, because most of the time they assume that because two are growing, they have to eat for two. And they keep on piling on the weight, and then they land up with preeclampsia and GDM. So it's very important that you counsel and also talk to them about the cost which is involved. Because when it's going to be
and frequent surveillance for GDM also.
And all that. And because when they're going to need a delivery, admissions are more common in twin pregnancy. So they have to be ready financially also when you have a multiple pregnancy on hand. And any change in the frequency of visit compared to a singleton, I think Dr. Ranu, can you take that question?
Yeah, hi ma'am. Yeah, frequency of visits. Actually, every month, as in normal pregnancy. Later on, we can do it every fortnightly visit. But in my practice, I routinely, if patient is undergoing ultrasound that is required to frequently in multi-fetal gestation, so I skip 1 or 2 visits if patient is doing fine otherwise in her BP and sugar. So just to reduce her travel, because in Delhi there is long distance travel, so I usually don't call
So
them.
you individualize the protocol according to the patient's
Yes, due to distance or not, in especially multi-fetal pregnancy twins. So
But,
otherwise, routine like other antenatal patients, we have to be very cautious about their BP and sugar and her weight gain. And
Strictly screen them for UTI also.
Yeah, that also quite common.
Yes.
And can I ask Dr. Bharati to take this question? Like fetal surveillance, we heard extensive talks on that, but can you make it brief from our side? Like how will you put a protocol for this for these babies when they are dichorionic, diamniotic? I'm not talking about monochorionic at all.
Okay, twin pregnancy have almost twice the risk of most of the obstetric complication. Preterm labor and fetal growth restriction, they are the common complication of DCDA twins. So we can go for serial ultrasound from 24 weeks onwards for the measurement of different parameters. For example, for preterm screening, we can go for this cervical length by transvaginal ultrasound. And fetal biometry can be done every month after 20 weeks. And we can do more
No,
frequent
suppose
biometry.
there's no growth restriction. Would you still do a ultrasound every month? Is it mandatory? Suppose there's no growth discordance. Both are doing quite well.
Yes, we can do this every monthly.
No, I don't think I don't think that's quite necessary. Can like Jayashree, can you say, like, because that also adds to the cost, and as Dr. Ranu said, her patients are from very far away. So if there's growth discordance, then you will definitely do a protocol where almost like a singleton, you will call for Dopplers and biometry once in 3 weeks and all that, but not so for a babies which are doing well, and most of the time they do quite well. So, but as you said, individualization is also extremely important. When
Ma'am,
you're
if I
planning.
may say, for the DCDA twins, we would normally do a monthly, like a 20-week scan and a 24 when we combine the fetal echo, and then 28 and then 32 and then 36, and 32 and 36 with the Dopplers, because if we are suspecting any FGRs to set in, they would set in at 32. So I would do a monthly at 20, 24, 28, and then at 32, I do a Doppler. And then if the Doppler is fine, then I'll probably do another one at 36. That's how I do for an uncomplicated DCDA.
Jayashree, would you agree with that?
Yeah, monthly scans, I agree. And a color Doppler at a little earlier, I would do. 28.
So for a normal singleton, ma'am, we would do, and an uncomplicated singleton, we would still do a Doppler at 36. So we would just change that at 32 for the twins.
Oh.
And third trimester, 34, after 34 weeks, maybe a weekly surveillance is mandatory.
Yeah.
No, what I mean to say is, suppose there's no growth discordance, both are doing quite well, there's no growth restriction at all, there's no need to do a scan every month. You can do it based on how the baby's growth profile you're seeing, and only when growth restriction is happening, then you'll go for Dopplers. But the 36-week Doppler is for that late onset FGR. But for the early onset FGR, if there's no FGR, there's no need to do a Doppler at all. That's what, because you cannot add to the cost just because it's a twin pregnancy. So it should be like whenever there's growth restriction, the Dopplers come into play. You don't need to do a routine Dopplers when there's no growth restriction. But when for late FGR picking up, you can do a Doppler around 36 weeks. But usually twins do not need that because we have a plan of delivering them little earlier compared to a singleton. So, but doing monthly scans, if the growth restriction is not there, I think that can be.
So maybe I'm doing more IVF pregnancies, ma'am. That's why.
IVF, because usually they go for growth restriction and that's acceptable. But for an uncomplicated
Complementary Doppler, complementary Doppler.
Yeah, only for complicated.
Complementary Doppler, I tell them, CPA.
Yeah.
Only,
Dr. Ranu, like what are the maternal problems that you will think about when there is a twin pregnancy in the first visit? From the first visit, what are you going to anticipate? Yeah.
So there are many maternal physiological adaptations, and due to that, there are many complications which can arise. Initially, the patient can suffer from hyperemesis, and we have to deal with that in the first trimester. Later on, patient can land up into preeclampsia, which we have to regularly monitor in every visit. GDM is also one of the frequent complications. Risk of preterm, as with the twin pregnancy, is very common. So this is there in such patients. And also placental complications like placenta previa and placental abruption also is observed. Anemia, risk of anemia because of the carrying twins, and risk of postpartum hemorrhage. Additional risk is a concern of excessive increased monitoring and increased care, and also the weight management of the patient. So these are all the increased risk.
And to remember to tell our paramedical people that they cannot give IV fluids like that in twins, because there are going to be cardiovascular adaptations which are much more severe in twin pregnancies, and there's a very high risk of pulmonary edema, and that's why the tocolysis came into problem only because of multiple pregnancies, because they were like loading them with fluid and tocolytic agents, and mothers had died because of the iatrogenic complications. So be very careful with twin pregnancies because of the cardiovascular adaptations also. And as you said that vomiting, hyperemesis is very common in twin pregnancies, and higher risk of GDM because of the increased human placental lactogen. So they have got higher risk of GDM because of that. And your maternal screening test, there will be problems with interpretation when there's a multiple pregnancy. So the fetal medicine specialist has to be very, very on point to identify that and give us the correct picture when you have a multiple pregnancy. And any problem of obstetrics is doubled in twin pregnancy. So usually I actually, when there's an older mother and we have done an IVF pregnancy and she's landed up with a twin pregnancy, Jayashree, we actually tell them to go for a selective reduction of even one fetus because complications are more in those mothers when they are elderly. And acute fatty liver happens more commonly. Peripartum cardiomyopathy happens more commonly. And atypical preeclampsia is very common because they already have nausea. So you don't know whether they're having the warning signs and you may miss them. Actually, we lost an obstetrician here to twin pregnancy and atypical preeclampsia in one of our medical colleges here. So she missed herself that headache which was happening and she thought it was quite okay. She was taking her own blood pressures and we lost her to HELLP syndrome. So be very careful when you have a multiple pregnancy. It's not easy all the time.
Yeah, and ma'am, we also order maternal echo for all twin pregnancies
Yes.
at 28 weeks.
Yes,
So
definitely
maternal
we
echo
should,
for all.
we should. And Dr. Richa, what about the weight gain in the mother? Where Jayashree and Dr. Bharti had already touched upon. What will be your counseling to the patient when she comes? Because Jayashree said she'll make her walk, but what about the eating habits? Dr. Richa?
She's
Dr.
not
Richa is there? She's not joined? Okay.
So maybe 10% higher maternal resting energy expenditure anticipated. And so the maternal weight gain and timing of maternal weight gain are critical. And so we would, like ma'am said, I would tell them to not gain a kilo till about 16 weeks. Do diet, do anything, and then according to, as for Singleton, if she's under her BMI, if she's a BMI of 18 to 21, I'd allow her to gain about 12 to 14 kilos and almost similar weight gain as in Singleton pregnancies.
But actually, the practical point, what we usually say is listen to your body.
Yeah.
Suppose you feel more hungry, eat well. And suppose you don't feel hungry, don't listen to the neighboring person who said that she ate so much of almonds and cashews and that's why baby was fair. That type of thinking our patients have. So to tell them, eat correctly, eat properly what you have at home, exercise correctly, but don't lose weight because some tend to do that also. So we cannot go overboard. And studies are there where they have said the suboptimal weight gain before 24 weeks, actually that relates to poor babies. So you have to be very careful in that also. It's actually
So
a
ma'am,
double-edged
maybe that's the difference. I'm in Chandigarh, so we have Punjabis, we have BMIs of 30s and 32s and nobody below 27, 28. So we have to
It's not only Punjabis, everybody.
and we
is
have so
BMI
much
7.
GDM, ma'am. We have so much GDM on insulin. So
Okay. Yeah. You should counseling individualize it because each
Individualized,
practice is different everywhere. Yeah. And Dr. Sangeeta is there? Dr.
Yes,
Sangeeta?
ma'am.
Yeah.
Yes,
So already one panelist has touched upon that. There is an increased risk of preterm birth in multiple pregnancies. So how are you going to predict which twin pregnancy is going for a preterm birth? Are there any tools in our armamentarium?
Ma'am, there are, see, first, the clinical history will suggest if the patient is at high risk. Second is our imaging studies, and third is our labs. So in history, we'll get the history of previous preterms or a short interpregnancy interval or a history of ART procedure or some uterine abnormality or extreme BMI or extremes of maternal age that places the patient at a high risk of preterm delivery. Then on ultrasound, the gold standard is cervical length assessment. That is to be done in the second trimester scan, where less than 25 mm will place her at a higher risk of preterm birth. And definitely assessment of chorionicity in the first trimester is very important because if it is monochorionic twins, she's definitely at a much higher risk of preterm delivery.
Yes.
And in labs, we don't do routinely fetal fibronectin, but the literature suggests that. Yeah, we don't have the facilities.
So at what weeks you will start your cervical length screening for multiple pregnancy? What is Mucosal
16 weeks to 24 weeks is the time. So usually when we do
earlier.
the level 2 scan, that is the time when we can go for the first assessment of
So before
cervical
16
length.
weeks, you would start. So actually, with your NT scan, we can see a cervical length and
Yeah.
probably do it every 15 days.
Mm.
And Dr. Sasmita is not there. So how will you reduce preterm birth in a twin? Are there any tools in our hand? Progesterone.
But
Everybody is like,
if it is asymptomatic, we're just going to monitor her. And the guidelines do not suggest use of progesterone and prophylactic cerclage.
is it
But
the truth? Is it the
in
truth?
in
Is it the
practically,
truth?
we give progesterone to the twins, and also if it is an IVF conception, we do suggest them cerclage also.
What form of progesterone you give?
I usually start her with the dydrogesterone, which continues from the first trimester till about 24 weeks.
Okay.
And then in case she has some symptoms, we prolong it. Otherwise, at 24 weeks, I stop dydrogesterone.
What do the other panelists use progesterone?
I do intramuscular progesterone, hydroxyprogesterone.
You give the
Light on the
progesterone
pocket.
caproate.
No, first trimester I do dydrogesterone till
Okay.
around 12 weeks.
Okay.
Then switch over to every 15 days IM progesterone. There was
Caproate.
some controversy in between, but I thought it was
Yeah.
I don't know. It was
I
industry
was also
related.
using, ma'am, but after hearing those controversies, I stopped using
Yeah,
IM
so
progesterone.
I've stopped using
I think it was
dydrogesterone post
industry
8
driven.
weeks because we've had patients of AFLP. We had reports of AFLP also on dydrogesterone. So
Dydrogesterone.
my route is 200 per vaginum capsule like vaginal progesterone, 200 milligram twice a day. So 400 per day of the capsule.
Yes. Even
When
I
cervical length is normal.
Yeah.
When cervical length is normal, there is no role of use of progesterone or cervical
No,
cerclage.
that
But when
is
cervix
that is
is
okay.
short,
We're not doing cerclage. We're not doing cerclage.
Prophylactic progesterones.
so
Prophylactic
vaginal
multiple
progesterone may be
400 milligram.
considered when cervical length is less than 25 mm. Vaginal progesterone, 200.
So there are two people with vaginal progesterone, one with IM progesterone, and there are two with dydrogesterone, right? Or any other panelists want to give their
vaginal progesterone, ma'am, we are considering.
You're giving vaginal progesterone. So there are 4 for vaginal progesterone, 2 for dydrogesterone, and 1 for IM progesterone, right? So, do you definitely feel that it reduces preterm birth when you give progesterones?
IM progesterone is time tested, it is, we used it for so many years. Suddenly, I think, it was industry driven because after that controversy, so many companies came up with dydrogesterone, first initially it was only Abbott with Dufestone. Then suddenly, so we need to, look into all these practices.
That's why I'm talking about this controversy, because when you read the trial which was done in NEGM about IM progesterone, the drug was not withdrawn because it caused a complication. They just said they did not find it useful, but when you compare it with the previous trial which said IM progesterone is useful, and the second trial which said IM progesterone is not good. The problem is the first group had a different cohort and the second group had a different cohort. The first group had black women, the second group had white women. In black women, they found IM progesterone to be useful, and in the white population, they did not find it to be useful. But when you talk about the Indian population, we find that IM progesterone is quite useful to prevent a preterm birth, because the logic is it will act at the myometrial receptors. So actually it will help much better compared to the vaginal progesterone. But because FDA said that it's not useful in a white population, I think we have gone back. Now it is time that the Indian researchers put up a study to say whether it's definitely not useful for prevention of preterm birth, because in my patients with a prior history of preterm birth, when I have given IM progesterone, it's definitely worked. And I agree with Jayashree, but it's not. It is not.
And
Doesn't
one
need
more
to be
thing
withdrawn.
about this vaginal progesterone, it leads to a lot of infection,
And
Our
they have
population maybe
and they have got bloody discharge also. They complain. We give you
hygiene is not, it's an issue here. Like many of them come with sometimes it's blood stained, and sometimes they get these fungal infections. Maybe they don't wash their hands. I don't know what is the problem, but the Susten gel and vaginal progesterone, whether it's gel or tablet,
Sure.
Definitely after 2 weeks or 3 weeks, they have itching, and then infection, as we all know, is the commonest cause of
Okay.
preterm labor. So
Okay.
I'm not very fond of that. Yeah.
And as you say, dydrogesterone has just blown up the market. So everybody is
Yes.
now into like talking about
Yeah.
dydrogesterone
Yeah.
to everything. So, but I don't know whether an oral drug can work in a uterus which is becoming like 20 weeks and all that to prevent a preterm birth per se. It may be used for threatened miscarriage, probably a recurrent pregnancy loss, but may not be for preterm labor. But vaginal progesterone is acceptable in almost all the guidelines for prevention of preterm birth. As Jayashree said, it has to be used very, very hygienically, so that it doesn't lead to an infection. And IM progesterone, I think, can be still considered, but we don't have studies to back up, so you have to listen to what the other group says also. And but when there's a short cervix, definitely you should give form of treatment. I was talking about the prophylactic aspect with no short cervix, just because she's a twin pregnancy. So one panelist said that they will do a prophylactic cerclage. Is it accepted?
No, ma'am.
There is no role of prophylactic cervical cerclage,
Shanuji,
according to me,
Yeah.
according
So,
to
ma'am, one
guidelines.
is that prophylactic cerclage is not accepted just because it's twins or multiple gestation. You will not do it. In fact, even incidental finding on an ultrasound of a short cervix with no history of preterm birth is also not an indication for. So the only indication I could come across in the guidelines for cerclage in twins was one is an emergency cerclage when the cervix was dilated more than 1 centimeter.
Yes.
And then there was one guideline, I think FIGO, which says that if the cervical length is less than 15 mm in twins on ultrasound, so ultrasound indicated only FIGO, less than 15 mm is the only indication. So there is no other indication for cervical cerclage.
So let me ask an honest answer from the panelists.
Yeah,
What
I
you said is
don't know.
totally acceptable. How many with an IVF twins will put a suture?
No, I would err on the side of caution, and all the twin pregnancies, I want to do a transvaginal sonography for cervical length on empty bladder, confirm the cervical length, and then I would err on the side of caution, like I would rather put it, and encirclage, many times it is not done higher up enough, when push the bladder and do a Shirodkar, it's much more effective than a McDonald's. So I think
But a recent study has said when you don't have a prior history of preterm birth, and this time she is just twin, and you are doing a cerclage just because you don't want a preterm birth, when you're not identified as short cervix, it will actually cause a
increase
preterm
the
birth.
risk of
It will
preterm
increase
birth.
that has been proved by studies now.
That's in the FIGO guidelines that
FIGO
if you prophylactically, you are in fact increasing the risk of preterm.
Preterm birth. So check for a short cervix. And if there's a prior preterm birth history, definitely you will be doing a screening
do
to
the
cervical
scan
length.
yourself, rather than,
do it
because they
as-
always do a trans-abdominal scan, the radiologist, and they'll say normal cervix. The first intricate thing of funneling, and that could be missed, on trans-abdominal scan. The false bladder and all that, yeah.
Yeah.
So, ma'am, if I may intervene, even with funneling, they say that if the cervical length is still more than 25 mm, even with funneling, is not an indication for cerclage. In such cases where you are in doubt, you could consider progesterones, but not cerclage.
Cerclage, okay. And what about the pessary?
So, ma'am, the pessary, the largest study, which was the Stop Pit 2 study, which was carried out in about 57 centers in Europe and the UK, they did not find any usefulness. So the only one indication of that I could find of the pessary was that when you've treated a TTTS with a laser ablation or something, you've done a procedure, then you would just let the pessary be till the time you want to carry on the pregnancy.
Prophylactic pessary then.
Prophylactic pessary only if you've done a procedure like a fetal reduction or a laser thing.
Yeah, so now there's no evidence, insufficient evidence to say that a pessary will help when there's a twin pregnancy and a short cervix. You have to either think of progesterones or cerclage when it's becoming very short. Pessary may not help when the process has started. Dr. Srishti, what about bed rest, hospitalization, tocolysis in a multiple pregnancy? Dr. Srishti is there?
I think she's there. I saw her.
Dr. Srishti, please unmute yourself, please. Yeah.
Ma'am, can you hear me?
Yeah, we can hear.
Good evening, everyone. So the role of bed rest and tocolysis both is questionable for preventing preterm birth. So tocolysis bed rest generally neither decreases the risk of preterm birth and nor does it lead to reduction in the perinatal morbidity or mortality. Although Cochrane review, it suggests that routine hospitalization may increase the likelihood of preterm birth in twin pregnancies. Limited physical activity may be undertaken to decrease the risk of preterm birth, but absolute bed rest is not advisable. And if we talk about tocolysis, similarly, tocolysis is generally used only for short-term prolongation of the pregnancy, which is required for administration of corticosteroids, or if we want to shift the patient to a tertiary high care center. For that duration of time, only tocolysis is advisable. And tocolysis in multiple gestation has to be used with a lot of caution, as you've already highlighted, because of the increased cardiovascular demands and change in the cardiovascular status of patients in multiple gestation. They are already at cardiovascular overload. So tocolysis has to be used with caution, like beta-mimetic agents should not be used in such patients as they can lead to cardiac failure in these patients. So nifedipine, calcium channel blocker, that is the first choice of tocolysis in these patients.
Would you use magnesium sulfate? Suppose you're going to combine it with neuroprotection before 32 weeks.
Magnesium sulfate is given if the preterm is less than like 32 weeks, and magnesium sulfate is given for neuroprotection in these patients. Yes.
Yeah, thank you. And Dr. Sonal is there? I don't think. Srishti, can you take these questions? What about prophylactic steroids? Just because you think she will go for a preterm birth, are you going to give her steroids?
If the patient is
all your twin pregnancies
in a single, if she is at high risk of delivering prematurely, then we can give a single course of corticosteroids in these patients between 24 to 34 weeks of gestation, and including those patients.
But if there's no risk of preterm delivery, don't give at all. Yeah, because there's no risk of preterm, she's doing fine. I don't think steroids should be given.
No, then it is not required.
Dr. Sonal, she's not there. So what is the most important counseling point before you, before the delivery of twins? Like, will you counsel that the vaginal delivery is going to be at more risk for the patient and all that when you're counseling the couple? Dr. Srishti?
Yes, ma'am. Sorry.
What is the counseling point which is there, like that you should be very careful on when you're talking about delivery to a mother of twins?
These patients, the patients with multiple gestation, they have to be counseled very properly. We have to take an informed consent about the mode of delivery of twins, that whether they are fit for vaginal delivery or a cesarean section, or they may require vaginal plus cesarean, like if the after coming twin is stuck in those cases. So an informed consent regarding the mode of delivery, regarding the complications which can occur while the delivery, and they have to be completely told to the patient, and proper counseling needs to be done. And a planned vaginal delivery carries no increased risk compared with planned cesarean delivery.
Yeah, that they have to be told that vaginal delivery is not so not complicated just because it's a multiple pregnancy, but they have to be prepared. Suppose we say like we have delivered the first one cesarean vaginal, the second has gone for a transverse, and I'm not able to do the podalic version. I may go for a cesarean. All that has to be told to the patient.
Yes.
And when will you deliver, Dr. Bharati, in DCD8 twins? Like how long can you wait?
Yeah, in a well-dated, uncomplicated dichorionic diamniotic twins, we usually recommended that delivery between 37 to 38 weeks. This is because the DCD8 twins each have their own placenta or amniotic sac. So it reduces the risk associated with the sharing single placenta. So delivery is recommended at the gestational age of 37 to 38 weeks.
Okay.
And delivery should not be advisable beyond 39 weeks because it may lead to risk of fetal death.
And Jayashree, like, what is the criteria which you will have for offering a vaginal birth in a twin pregnancy? And
Like first will
supposing
have
it's
to be a cephalic presentation,
okay.
and it shouldn't be an extreme preterm birth. Just last week, one of my IVF twins, first cephalic, second transverse, I delivered her vaginally. First was a 2.1 kg delivery, vaginal. It was smooth, it was a smooth delivery. Then the transverse, I called the anesthetist. I gave her 2 grams IV Maxilf, and so that to relax this thing, the back was up, so pulled the feet, internal podalic version, and delivered her by breech by pulling the lower limb. So lower limb you have to identify with that malleolus being perpendicular to the distal fibula and tibia, and do a routine
And
Morris
you can
Melling.
use an ultrasound also, intrapartum ultrasound.
I didn't have the ultrasound in the labor room at that point of time, so I did it clinically just with my right hand, and I pulled the
Breech
leg
by breech.
and breech, and with my right hand I moved the head a little up, and then while shoulder rotated 90 degree and delivered the anterior shoulder, then made sure the spine was anterior, and with Morris Melly weights delivered the head. So both of them are doing well, except for jaundice, they're still admitted. Just happened last week. So it is fresh in my mind.
You're very courageous that at this time, at like this point when there's so many medical legal issues, you were given an IVF twin vaginal birth. Because I think most of us are scared to give a trial of delivery to her, but it's what you've done is the best method. We should always offer vaginal birth, even if it's an IVF for
The
twin
ideal,
pregnancies.
2.2 kg weight. If they are lesser than 1.5, we are not going to affect
So
them.
how long will you wait between both the twins?
Max 20 to 30 minutes, max
Suppose
20. And
suppose it's
continuously
not
monitoring of
starting.
CTG. Yeah.
Suppose it's not starting at all, labor pains.
Pardon?
Suppose pains are not starting after the first baby is delivered. What are you going to do? The first is
If the
delivered.
cervix closes.
No, the first is delivered. The second, there are no contractions at all.
We can
Uterus is
start
relaxed.
Pitocin if the assuring fetal heart rate, if the CTG is good, start up with Pitocin, but we have to make sure the cervix doesn't close on the presenting part,
How do you stop that cervix closing?
So you're giving her Pitocin and then do an artificial rupture and pull the do the internal podalic version.
But you have
and
to be
pull.
very careful because cord prolapse can happen.
Yeah, cord prolapse. But in transverse and breech, even if cord prolapse happens, the fetal heart doesn't really go. In 2 or 3 cases, whatever I've done, once I had a cord prolapse, the baby still was okay.
Yeah, I also had that, but with the head, unless the head is fixed, I don't think we should do an ARM in a twin pregnancy. Because when the head is not fixed and you do an ARM, it is inevitable that the cord will come out. So always
this is a
wait
transverse. Second was transverse. Okay.
So that's what, even for a transverse, you just wait for some time for the contractions to start. And then probably because if it's transverse, may be very difficult to allow because the cervix invariably will close. So that's going to be very, very critical when you have a second baby going into transverse.
This patient, the cervix was still open and back was up. So I was scared for cord prolapse, but I put in my hand and put in, I didn't allow I didn't allow that much time. Delivery interval was around 10-12 minutes.
So that's a take-home point. Suppose you have a transverse lie, do an ARM, put your hand very, very quickly inside, go and catch the breech and bring it out. Don't wait for the contraction. Start Maxilf also, so that you have a relaxed uterus. And when we did an internal podalic version, we called the anesthetist and asked him to give a relaxant.
I called the anesthetist. We have 24/7 tertiary care center.
So we gave a relaxant and then put our hands in. But for us, the membranes ruptured by itself. Then we had to put our hand in and bring out the baby because it was already transverse, so we didn't want to wait. But cord prolapse, you have to be very careful. And suppose it's second is cephalic, wait for the uterus to contract, start your oxytocin, wait for the head to get fixed, then you do an ARM. But for a transverse or a breech, probably you can do a ARM by yourself and relax the uterus and bring out the baby by a podalic version if it's transverse, and breech, probably a assisted breech extraction will be useful also. And please remember the time interval, because medico-legally it will become problematic, because I had a twin, both one was cephalic, second was breech. And second, I started oxytocin, and when the breech fixed and then I delivered, the time interval was almost 3 hours by that time. But we were doing a continuous CTG. The baby's heartbeat was quite fine. Both did quite well. But after 8 months, the grandmother came and fought with me, saying the second baby has got a audiometric problem. And she said, that's because you delivered the twins by vaginal birth. If you've done a cesarean, this audio problem won't be there. So that is, long-term problems are also there. So be very careful when you document. Tell your patient that you waited with the monitoring and everything was fine, and that's why you waited, because either ways, obstetrics is I would say a very bad word, a screwed procedure. We're totally gone. Either here or there, everywhere will be blamed. So be very careful with your documentation. And this we have already talked about, Jayashree, because you will offer an internal podalic version with breech delivery if the second is a non-cephalic presentation. Dr. Kavita is there. Dr. Kavita is not there. And suppose, can I ask Dr. Renu to take this? Preterm twins, suppose it's a growth discordance, how are you going to deliver?
So, ma'am, in case of preterm twins, a trial of vaginal delivery would not be a very safe option. So, after a proper assessment, I think a course of cesarean delivery would be a safer option for such patients.
Yeah.
And
growth discordance, suppose one is big and the other is small.
yeah, in such case also, I think to deliver by a LSCS would be a safer option than to go for a normal delivery. Yeah.
Jayashree will offer a vaginal birth for this situation. One is big, one is small, and it's a preterm twin.
No.
Cesarean is safer always.
Yeah, cesarean is safer. There's so much of discordance then.
And previous cesarean, and there's a twin pregnancy, what will you do?
If she's cephalic, I can deliver her normally.
Okay. Anybody else would disagree?
Ma'am, but not induce her if she comes in spontaneously with a very good bishop.
Section at
I
all.
deliver with first cephalic.
No. Even singleton, I don't induce. But if she comes in active labor, we can do a vaginal delivery.
Okay. That's what I've said. Tolac is quite, you can do it comfortably when there's a, when the patient is already
the baby
in
weight
labor.
is normally lesser, you know.
So they deliver quite fine.
They deliver
But
quite
your internal podalic version may be a dangerous point there. So,
that I won't risk. Both cephalic and average weight of 2 they deliver very easily.
So the second patient is 29-year-old, Gravida 4, Para 1, Line 1 with 2 abortions before. This also is infertility conception, married for 7 years, known hypothyroid. And first she had a termination because of multiple anomalies. Second was a spontaneous abortion. Third was a full-term cesarean. Fourth, present pregnancy. And this is a monochorionic diamniotic twins. Dr. Komal, she's there? No. Can I ask Dr. Bharati to take this? Is it different, the maternal surveillance, when it's a monochorionic twin?
Yes, monochorionic twins,
I'm not talking,
there are 5 times higher.
Not talking about the fertile fetal surveillance, the maternal part.
Maternal. Monochorionic twins are more complicated twins. So screening and follow-up in monochorionic twin pregnancy is very important. We have to go for viability scan in early trimester, then NT scan between 11 to 14 weeks, and with first trimester screening of Down
So you're
syndrome.
saying there'll be more of visits when there's a monochorionic compared to a
NC visit should be more as
more
compared to the dichorionic.
Dichorionic. And this
Almost
already
double
talked.
visits are required.
So
Yeah.
Dr. Nidhi is there? No, she's not there. Can I ask Dr. Richard to take this question? MCDA twins, when will you deliver?
So she's also not there.
Okay.
She's not there.
Okay. Dr.
So-
Sangeeta? Sangeeta? Dr. Sangeeta is there?
Ma'am, if it is an MCDA, and if it is an uncomplicated, I will try to prolong her beyond 34 weeks. 35, 36, I'll try to deliver her.
Oh, okay. And suppose it's a vanishing twin, what will you do? Dr. Nidhi is not there. Can you take that, Dr. Sangeeta? Vanishing
We are not
twin.
going to have any extra monitoring because vanishing twin doesn't pose
Cause
any
any problems at all. Yeah.
No.
And Dr. Ranu, suppose there's a discordance for anomalies, there are complications when there's a discordance. How will you manage? This is a monochorionic twin and I'm talking about.
In monochorionic, right?
Yeah.
So in monochorionic, it will be either we can go for we'll have to monitor her very closely, and if there is risk, then we can go for selective termination also of the affected twin, or we will have to go for intervention to protect the healthier twin. So that can be in the form of cord occlusions and use of laser and things. And so it will be done definitely in tertiary care center, which is equipped with all these facilities. So and that will be very important for that.
Yeah. And it will depend on the severity of the anomaly, and the certainty of diagnosis, likelihood of survival of the anomalous twin, because not all anomaly twins will be like incompatible with life. Some can also survive also. Chorionicity is very important. And you have to think about the effect of the anomalous twin on the normal twin, because suppose one becomes polyhydramnios, it's going to cause an increased risk of preterm birth. The ethical beliefs of the parents, because many times, many will say, I will accept that anomalous twin, so don't do anything. So you have to talk to the parents also before you take a decision. And the problem with DCDA, when they have an discordance for anomaly, it's a polyhydramnios. Otherwise, in a DCDA twins, it will not have much of effect. And Dr. Richa is there. Dr. Richa, suppose you have identified an intrauterine fetal death of one twin. Will you rush to deliver a diagnosis? Dr. Richa is there?
No, madam, Dr. Richa is not joined.
Okay, can I ask Dr. Sangeeta or Dr. Shanujit?
So, ma'am, we will not rush to deliver a diagnosis, because if we are thinking of any neurological problems, they would have anyways happened in the immediate demise,
Death of
after the immediate
the-
demise. So we can, but we have to counsel the patients very well that they can lose the other twin also. So the co-twin can die in about 15% of MCD and about 3 to 5% of DCDA twins. And if we have to we have to give a prognosis to the patient, to the couple, then we have to do an MRI for the surviving twin at least 4 weeks after the demise,
Yeah.
and then prognosticate accordingly.
It was very clearly said by Dr. Divya also about this. When you have one twin dying, the other twin, if it's a preterm, there's no point in rushing and delivering, because you will lose both. Suppose it's not a preterm and it is all cross 34 weeks, deliver at once, so that you have a chance of having a viability. And suppose you've got a preterm IUD of one baby. Remember, as Dr. Shanujit said, there may be a neurological damage, because already the damage has happened because of the hypotension which happens in the normal surviving twin, because the blood just rushes from the live twin to the dead twin. So the hypotension is the one which causes the neurological damage. So you cannot prevent it at all. But what you can do is, like, suppose you suspect that a damage could have happened, you have to do an MRI 2 to 3 weeks after the death of the co-twin to identify a multicystic encephalomalacia. So if it's absent, it will have a very good prognosis. So the main point is the gestational age when the one twin is dying, so that you can take a decision for the other twin also. So don't rush to deliver just because you identified a IUD of one twin. And Dr. Sangeeta, are there any maternal risk which you should anticipate when you have fetal death and the other is surviving, and you want to continue the pregnancy? Dr. Sangeeta is there?
Yes, ma'am. Yes, ma'am.
Hemorrhage, infection, coagulation, because many will get scared, particularly
especially
in second.
Yeah. Ma'am, there is a risk of DIC if the pregnancy is prolonged beyond 4 to 5 weeks after the death of the co-twin. And there is high risk of malpresentations. In case the pregnancy is prolonged beyond a certain period, there is a risk of infections, chorioamnitis, especially if there is a rupture of membranes. And
but
we have
actually, the studies have said there's no high risk of coagulopathy just because one twin has died.
if it is beyond 4 to 5 weeks, then we have to be.
No, even then, they're saying it will not be so high, and infections will not be there if you're not doing any manipulations, because it's quite in an aseptic area. So you need not worry about infection or coagulation. Just wait for the maturity of that gestational maturity of the other twin before you think about it. And remember that, as you said, malpresentations will be very common.
Yes,
and you can have non-reassuring NSTs, and cesarean deliveries are much more common. Preterm are definitely common, but there are no major complications which will happen in the short term. And can you do vaginal delivery when you have a twin which is died and the other is alive?
Yes, if there are no other obstetrical indications, we can go ahead with
The
vaginal.
vaginal delivery. But we talk about all that, but I think practically I would rather
It
go
becomes
for
difficult.
very
Yeah.
difficult to take
Counseling the
decision.
patient is very difficult then.
And only a person who's as bold as Jayashree will do all that and
They
try.
Yes, ma'am.
Dr. Shanjit, like uncomplicated monochorionic twins, very, very lucky you are. Nothing has
Yeah.
happened.
So
Will you do for a vaginal or a cesarean delivery?
Ma'am, again, same as like, though I'm not as bold as Dr. Jayashree, but even then, uncomplicated, irrespective of chronicity, vaginal delivery is indicated, first cephalic, both cephalic. And as for cesarean, if you're doing, that is 36 completed weeks. 36 plus 0 to 36 plus 6.
So even for MCDA twins, even though that theoretical part of all the babies joining with each other, not coming out, it will not happen in all your deliveries. So you can go for a vaginal birth. And suppose it's a patient has undergone so much of treatment history, and now it's come up to like 35, 36 weeks. It's undergone treatment. So will you rush for a cesarean or a vaginal birth you'll give? Srishti?
Yes, ma'am.
Vaginal birth, is it okay when there's a treatment like a laser ablation which has been done?
No. Ma'am, vaginal birth can be given, can be offered to such patients if the pregnancy has been going well and there is no other contraindication to vaginal birth in these
And
patients.
you can wait like DCDA when the treatment has worked very well and the babies are doing well. You can wait till 37 weeks, even in a monochorionic twin pregnancy. You need not rush for a delivery. And when will you deliver a monochorionic monoamniotic twin? Srishti?
Ma'am, monochorionic
32 weeks.
between 32 to 34 weeks, they should be delivered because there are always increased chances of cord entanglements and cord complications. So they should be delivered by then, by cesarean section.
Yeah. Anybody would like to say anything before we wrap up the session? Any of the panelists? So I would like to say, based on all the inputs from the panelists, determination of the chorionicity is a very, very important part of management in a multifetal pregnancy. And there is a high chance of spontaneous losses before 12 weeks in monochorionic twins as the vanishing twin. And reduction can be done between 11 to 13 weeks, but it is contraindicated in monochorionic twins or a single fetus reduction. And suppose there's a discordancy for anomaly in dichorionic twins, there is a high risk of preterm labor because of polyhydramnios in the anomalous twin. And monitoring in twins should start from 16 weeks onwards. And in monochorionic, 2-weekly ultrasound and Doppler is advisable. If in monochorionic, there's an IUFD of one twin, the chance of death of the other twin is 12 to 15%. There is a higher chance of preterm delivery, brain injury, and a cesarean delivery, but there is no increase in chance of hemorrhage, infection, coagulopathy. Remember that the brain damage which happens is because of the acute hypotension which happens in the survival because blood goes from the alive twin to the dead twin at the time of demise. So immediate delivery after one twin demise may not help the survivor. And if IUFD one twin happens after 34 weeks, please remember to deliver at once. And monoamniotic twins should be delivered between 32 to 34 weeks because of the problems which can happen with the babies. And these are my references. And I'd like to thank all the esteemed panelists for a wonderful session, as well as Dr. Monica for the opportunity and Dr. Purva for the coordination. Thank you so much.
Thank you so much, Sharmila ma'am. A very wonderful interactive panel full of practical take-home points and really gave us room for, a lot of thought process of vaginal deliveries in twins in this era with IVF pregnancy. Hats off to you, Jayashree ma'am and
Thank
Sharmila
you.
ma'am. Still keeping the art alive. We have done internal podalic versions. Bharti, I don't know whether you have done or not, but
Yes,
we have
yes.
done of internal podalic version. Of course, they were not IVF pregnancies, but it was one of the most fulfilling obstetric maneuvers.
Actually, we have a very good team at Jupiter. The babies are still admitted here in Jupiter for jaundice or something. But we have a very good team of neonatologists, anesthetists, and junior gynecologists, and everybody came to see because they hadn't seen one. So yeah, it was a nice high point for us last week.
I had done it in a younger age. Now I don't have the guts to do all that. So I go
No,
for
you're
a
right. We have to be very, very.
as I'm becoming older, I'm becoming more scarier. It's become more scarier obstetrics.
Yeah, maybe in the next
I
few years I'll stop vaginal deliveries also. Yeah, I agree with you. Completely agree with you.
it's not worth that patient
Yeah,
coming and
not worth,
talking.
not worth.
And that when that grandmother came and fought with me, that
Yeah, I know
I
it's
was
not.
so scary,
Yeah,
so
we
scary.
meant well, but that
Ah.
intentions don't count, no?
Yeah, yeah. Because
Yeah, yeah.
the mother and the father, they were accepting, but this grandmother, I don't know where she popped up from. And then after 8 months, she came with babies and said, one is not hearing well, and that's because of your vaginal birth.
So otherwise, ma'am, any manipulation will not have any
No, it
sort
won't.
of
It is like any
wound.
twin will have a higher chance of having a problem because they're sharing all the genetic material. No, so it gets shared, and you will see that most of these babies, like not all thrive so well. One will thrive well, the other will be always a weaker person.
Yeah,
So
yeah.
that is because they have got that from their birth, intrauterine. But the easiest person to blame is always the obstetrician.
Always the obstetrician, yeah.
So ma'am, could be a special consent which can be formed for vaginal delivery
You
of twins.
should give it a written consent, and as all the panelists said, it should be an individualized protocol, individualized treatment for multiple pregnancy based on the
You can
patient.
feed everything, in Chat GPT. We are getting very good consent forms nowadays for individual. Just you have to tell them, कि I'm doing a TLH for itne weeks pregnancy, 18 weeks uterus previous to section. So the consent comes as, like his bladder, ureter, and bleeding, and bowel, and everything specifically mentioned.
Even in this Chat GPT, you read the consent also. It may
Yeah.
give something extra also, which you don't
Yeah,
need
yeah.
also. Yeah, thank you so much. I would like to thank all the
Thank you.
panelists.
Thank you. It was
Thank you.
excellent. Thank you,
ma'am.
Monica.
Thank
Thank
you.
you. Nice
Thank you,
meeting you.
Sharmila ma'am, for such an interactive panel
Thank you.
discussion.
Thank you,
Thank
Bharti.
you.
Personally, the
Thank you.
questions
ma'am,
asked
for
were very
inviting
thorough
us.
and very informative.
Thank
Thank
Ma'am, you
Yeah.
are too good, ma'am.
Brilliant
Dr.
always,
Sharmila,
Dr.
yes.
Charmila.
Thank you.
So, madam, I'll take another 30 seconds to thank everyone who's present, all the brilliant panelists, our dynamic moderator, Jayashree ma'am, for her, real life inputs, and Shanuji, Srishti, who took my call. I think they don't know me, but they took my call late at night, agreed to be panelists, and I was specifically looking for fellows of ICOG. So, madam,
Much,
thank you
ma'am,
so much.
for
It's an
having
honor, ma'am.
us.
Thank you so much.
Thank you so much.
And
It
Purva
was
was
a
so
nice
Purva was
interactive
so
session.
worried. No, Purva was so worried. She kept on saying, "You send the answers also because people are asked." I said, "These are a practical thing, and you have to answer from what we are doing because many times what the guidelines say is always not right because that will not be acceptable for our group of patients also." So this is how we also learn from the other panelists, and the inputs from so many eminent experts is always an accepted this thing. Thank you so
Yes,
much.
ma'am.
Very nice.
Purva,
Thank you.
they are the backbone of the program, madam, and I would recommend everyone to take part in the certificate courses of ICOG. They are so informative. And very soon, yeah, there are multiple courses coming up. Just keep a lookout on the website of ICOG. Charmila ma'am is very, very active there. And you
Next
will
week, we
get
have got on medical disorders in pregnancy, and we have got very good speakers, all the topmost from the country. Please
speakers, madam.
join for that. It's a very
Yeah.
precise. We will finish on time. Three
Yes.
hours.
Yes, and there's a test. There's a test
Definitely.
also. So thank you, Dr. Vivek Sharma, for joining in from Ahmedabad. And thank you, Team Intas. Thank you, everyone present. Till we meet again, our next webinar is on 8th of July. It's on obstetric collapse. So please watch out this space for next information. Thank you so much.
Thank you.
Thank you. Have a
Thank
good,
Thank
have a great weekend. Bye, ma'am. Bye.
Thank you, Monica Didi.
Thank you. Thank you, Bharti. Bye.
Hello,
आ जाओ
ma'am, should I close the meeting?
Okay.
Hello.
सॉरी मैं एक्चुअली वॉशरूम गई थी जल्दी जल्दी उठ के तुम वहां का दरवाजा बंद